And
All right. Good morning, everyone. Good afternoon, rather. And welcome to the part two of recall of NEET MDS 2025 exam at DBMCI MDS. I am Dr. Himani Joshi. And let's begin with the mega recall part two with oral surgery. All right. If your friends are about to join, you can ask your friends to join in. The live session is on. If there are any doubts, anything you guys want to ask, it is best to ask during the live session. So if you want your friends to join in, please ask them to join in. All right, so let's begin with the first question, which said that trismus is caused due to which of these muscles. Now, before I tell you the answer, guys, if you people can tell me what you have marked, whether you have marked masseter, thinking that tetany and trismus, this is the biggest muscle and nice elevator of mandible, and if this is affected it will cause trismus. Or whether you have marked medial pterygoid, because when we give inferior alveolar nerve block, this is the muscle which gets injured and it can cause trismus. Or you have marked lateral pterygoid, because that's the first muscle or the most important muscle directly connected to the disc, to the joint, to the condyle of mandible, and any pain, spasm in this muscle can cause trismus. Or whether you have marked temporalis, because even for distractor pins, when we put pins here and it causes trismus of temporalis, it causes there is spasm of temporalis, it causes trismus. So what have you guys marked? I am here live with all of you to know your answer. Okay, so some people have marked B, medial pterygoid. Some people have marked masseter. Some people have marked A, D, B, A. All right. Guys, I think this question is inappropriate. You check any books in anatomy, any books in oral surgery, every book will say that trismus can be caused due to injury, spasm, or pathology in any of the masticatory muscles. Usually, in NEET, you are supposed to check the best answer. All right, you're supposed to check or you're supposed to mark the best answer, but there is no best answer for this question, which is why here at DBMCI MDS we have decided to report this question to the national boards. In the morning today, we have tried to go to the online portal to submit queries, grievances, and feedbacks to the NBEMS. All you have to do is put your email ID. There will be an OTP which is generated on your email ID. You have to choose the Department of Examination Conduct. You have to put that captcha, and you have to put the OTP which you receive on your email ID. But obviously, when we tried doing it, it was saying that invalid or error page. So we chose this email ID which is given at the bottom of the website, and this email, mail@nationalboard.edu.in. Collectively, we have requested to cancel this question from the NEET MDS 2025 exam. Okay, we have mentioned this question, the anatomy faculty, I, as a oral surgery faculty, we do not think that this is an appropriate question, and nobody can mark this properly. If there is a standard book giving one answer to this question, then we would be wrong. But we've not been able to find one standard answer, and practically speaking, also this question is inappropriate. So I request you all, you can just use this email ID, mail@natboard.edu.in, and you can request them to cancel this question as it is inappropriate. There is no one best answer to this question which can be marked. All right. So don't worry if you've marked this question or if you've marked anything in this question doesn't sound to be a correct question. All right. Now, don't think every question was like that. A lot of correct questions, a lot of good questions here. So let's begin with the other questions in oral surgery. The next question is a repeat question. It is a PYQ. Repeat. Those who have done the PYQs from the app and those who have read the explanations properly, I'm sure you've all marked it correctly. A patient presents with painful limitation in mouth opening. So there is pain, and the pain is causing a limitation in mouth opening. Otherwise, why would mouth opening be less? Because of pain, there is reduced mouth opening. with no prior history of clicking or popping. MRI of TMJ reveals the disc in the correct position in closed mouth view. There is no change in position on attempted opening. What line of treatment would you recommend him? Okay, now first let me tell you that the answer is A. Limit mouth opening, soft diet, and analgesics. Okay, soft diet and analgesics. Okay, you do not need any arthroscopic surgery, you do not need any discoplasties, you do not need any minimally invasive treatments like arthrocentesis. All you have to do is give the patient some rest by reducing the mouth opening, give him some soft diet because you cannot live without diet, and give him some painkillers. Why? What is the diagnosis of this case? Usually whenever we think of TMJ, we think of either ankylosis or we think of internal derangement. Nowadays internal derangement is the hot favorite of the NEET and INA examiner. So these are the two things which we talk about or which we think, especially when MRI and such things and disc position and all these things come into picture. First thing we think is internal derangement. Guys, the diagnosis of this case is not internal derangement, it is simply a lateral pterygoid spasm. It's simply a spasm of the lateral pterygoid which needs to be relieved. For some reason, there has been a spasm, some injury, some inadvertent injury, change of weather, infection, something which has caused a spasm in the lateral pterygoid. Because of that, the patient is unable to open the mouth, causing pain. Okay. Remember, if you think of internal derangement, the first stage, even the first stage of internal derangement has clicking, painless clicking. It does not fall into the painless clicking category. There is pain and there is no clicking. So definitely this is not a case of internal derangement. So you do not need any arthroscopic surgeries to bring the disc back. You do not need arthrocentesis. Okay. Now let me show you some screenshots of the notes where we have taught you exactly this concept in the recorded class, in the live class, and we have given you the notes of the same. So when we discuss the disorders of the temporomandibular joint, for some reason this is a little blurred. So the extra articular disorders, when we discuss muscle spasm, okay, there is a little blur here. For some reason, the muscle spasm is one of the reasons of trismus, of joint disorders which causes trismus. All right. And when we discussed internal derangement, we have very nicely discussed the early reducing stage, the late reducing stage, which are the reduction stages of internal derangement. In both the stages, there is clicking. The only difference is in stage 1, there is painless clicking, and in stage 2, there is painful clicking. So, since this question has no clicking, it is not internal derangement. Now, those who have not read it, those who do not know the concept, very quickly I will just explain you the concept. This is a normal TM joint. Okay, this is a normal temporomandibular joint. Okay, you can see that this is the glenoid fossa. Okay, cup like depression where the condyle will fit. This is the articular eminence. This bony protuberance is the articular eminence which stops the condyle from going excessively forward. This is the mandibular condyle, right? And this beautiful bow shaped structure in between them is the articular disc, right? We all know that it is bow shaped, it is the thinnest in the intermediate zone. Why it is the thinnest in the intermediate zone? Because constant pressure of the condyle makes it the thinnest. Anterior and posterior bands are thicker so that the condyle doesn't move. Normally the disc moves in congruation with the condyle in normal movements. Okay, so this is the normal closed mouth position that the disc, condyle and fossa are in alignment. They are in alignment. They are in this axis and they are in alignment. When the patient opens the mouth, when the patient opens his or her mouth, You can see that initially the condyle rotates and later on the condyle translates. It moves forward till it comes below the articular eminence. And as the condyle moves normally, the disc also moves along with the condyle. You can see that this is the retrodiscal fibers. This is the superior retrodiscal lamina. This is the inferior retrodiscal lamina. And this is how normally a mandible movement causes the disc to move along with the condyle. Very quickly, I'm going to show you a video and you will appreciate a normal biomechanics of the temporomandibular joint. Oh, okay, this is a PDF, so the video is not visible here. So in the class, we usually normally show you this video, and these are the stages of internal derangement. All right, painless clicking. So this is not internal derangement. Okay, so the answer to this question is the lateral pterygoid spasm. So all you need is just to give the joint, give the muscle some rest. If I have to draw it, this is the glenoid fossa, this is the articular eminence, this is the mandibular condyle, okay, this is the joint capsule, okay, and somewhere here is the lateral pterygoid plate. Okay, now we all know that from the medial surface of the lateral pterygoid plate originates the medial pterygoid muscle. From the lateral surface of the lateral pterygoid plate originates the lateral pterygoid muscle, right? Now we know that the inferior belly of the lateral pterygoid inserts into the neck of condyle in a place called fovea, condylar fovea, and the superior belly of lateral pterygoid goes and inserts into the articular disc. Okay, this is the articular disc, and the superior belly of the lateral pterygoid goes into the articular disc, and the inferior belly into the condyle. So basically, it is this lateral pterygoid muscle which is responsible for the actual movements of the disc and the talmeer or the coordination between the disc and the condyle. Okay, whenever there is injury, spasm, pathology, any problem in the lateral pterygoid muscle, first thing that it will have pain. Because of the pain, the muscle will be in spasm. And this is exactly the scenario because there is no history. The patient can open the mouth. You can see that in the question, it says that attempted mouth opening. So when he's trying to open the mouth, so when we do an MRI of the joint, okay, we always do it in two parts. One is the closed mouth position and one is the open mouth position to see how the disc is in the closed mouth position and to see how the disc moves along with the condyle in the open mouth position. So MRI is always done in two stages. Okay, so when the patient is trying to attempted opening of the mouth, he's able to open. So definitely it's not ankylosis. Okay, so this is causing pain. All right, so this is a case of lateral pterygoid spasm. All you need to do is give rest to the muscle, give rest to the joint. How will you give rest? Just ask him not to eat any hard foods. Give soft diet, which easily you can chew and just swallow. Give analgesics because analgesics and these NSAIDs have anti-inflammatories also. These are anti-inflammatory drugs also. So any inflammation in the muscle will settle down and limit the mouth opening so that the muscle doesn't have to work a lot. All right. So this is the correct answer to question number 2. Let's jump to question number 3 now. Okay, a child with cleft lip and palate comes to you. What would be the correct timing of surgery for cleft palate considering an optimal speech development? I don't even need to tell you, this is a PYQ which is repeated, I think, so many times previously that I'm sure that all of you have marked this correctly. The correct answer is 9 to 18 months. All right. Any child who is born with cleft lip and palate, there is a sequence of surgeries. There is a sequence of surgeries according to specified times. You can't just do any surgery anytime. Okay, if the child comes to you at 20 years of age, definitely you will do it late. But if the child comes to you at birth, you know the diagnosis, then there is a sequence which you have to follow and operate the patient in that sequence. It's a repeat question. We all have learned it. Just a quick recap from the notes. I don't know why this is coming blurred, but we know that lip surgery is done in 3 months, at least 3 months of age, when the patient, all the rules of Millard are followed. 10 weeks of age, more than 10 gram hemoglobin, weight more than 10 pounds, and TLC count is more than 10,000. That means there's no infection in the child. Okay. Palate surgery is always done from 9 to 18 months. It's a standard depending on the speech development. Now, why is this range? Why is there a range of 9 to 18 months? There is a reason for that. See, every child has his or her milestones. Okay. Sometimes a child may start walking early. Okay. Another child who is also absolutely normal may start walking a little late. Okay. So it's a range. It's always a range of milestone development. No pediatrician will ever tell you that, oh, 12 months a child has not walked, he's abnormal. No, there is a range from 9 to 18 months the child can walk. Just like that, speech development is also a range. Some children start speaking early, some children start speaking late. Okay, those who start speaking early, you have to do early surgery of cleft palate. Those who start speaking late, you can wait before doing surgery for cleft palate. Why? What is the reason? Why are you waiting? Because the more you wait, the more the maxilla gets the opportunity to grow. Okay. The only drawback of cleft palate surgery is a palatal scar. Okay. A palatal scar. So if this is the palate, okay, let me show you here. If this is the palate, okay, which should normally be like this, a single closed palate, but if there is a cleft in the palate, something like this, if there is a cleft, okay, what you will do, you will do a surgery, you will bring this part here, you will this part here, you will close this soft tissue of palate like this, and this causes a scar on the palate, and this scar causes a deficiency of maxillary growth. Okay, we all know that all patients who are operated for cleft palate, their maxillas may not grow properly like normal people. So they have transverse deficiencies of maxilla, they have cross bites as they grow. So they need more orthodontic treatments in future. Okay, so that is one disadvantage of cleft palate surgery. Disadvantage nahi, drawback. Okay, that doesn't mean that you will not do the surgery. You will do it, but you will postpone it as long as possible. Okay, you will postpone it till the speech comes. As long as possible, you will defer the surgery so that whatever maxillary growth can happen, you allow it to happen. What if you don't do the surgery till very late? You let the maxilla grow. You can't do that. Why? Because speech is something which needs to be learnt at the right time. Doing an orthodontic surgery and expanding the maxilla is easy. Doing a speech therapy to treat speech problems is very difficult. Okay, so you will give priority to speech. Based on the speech development of the child, you will operate on the cleft palate. All right, so this is why there is a range of 9 to 18 months as very clearly written in the DBMCI notes, and based on that there is this question asked. Okay, now I will add one point here, because INI people are one step forward. Okay, they will not just ask you cleft palate, they will give you split situations. Okay, that if it is a unilateral cleft lip, what will be the time, versus if it is a bilateral cleft lip, what will be the time. Similarly, if it is an isolated cleft palate, what will be the timing, and accordingly. Okay, so this is a delayed Love and Bailey given table which is there in the notes, which you all need to learn. Okay, this is the split timing of different cases, that if it is a only soft palatal cleft, you can do one operation at 6 months itself, because that is not related to maxillary growth. But if it is a soft plus hard palate, you have to do two surgeries. You can do soft palate at 6 months, or you can even do soft palate with lip surgery. And the hard palate, which is related to maxillary growth, you can do at 9 to 18 months. So two surgeries at different times. All right. So this is the timing. Depending on that, you have to learn this table, because and I may ask you a little advanced questions. So please learn this table. It is there in your notes, so you know it. All right. Next questions. Just give me a thumbs up if you guys are with me and if you are understanding everything. So, rapid dentistry, you're correct in thinking that joint inflammation can be there in that question, but even analgesics, most common of which are NSAIDs, will take care of the inflammation. So, you don't need to do an arthrocentesis every time because it is an invasive procedure. If you can take care of the same thing with drugs, it is always better. All right. Uh, okay. All right. Okay. Coming to the next question. In Champy's superior border mini plate fixation of angle fractures of mandible, which of these is correct? Now, this is purely a concept based question, purely a question which, if you know the concepts, you will be able to answer. Okay. Options are, it can injure the lingual nerve. Now, we all do Champy's superior border mini plate fixation. Okay. Obviously, if you're a very bad surgeon, if you don't take care of anything, you can injure the lingual nerve. But normally, the reflection is not so much that you can injure the lingual nerve. Just on the lingual side, one screw may go. Otherwise, the reflection of the lingual side is not so much that there is a chance of damage to lingual nerve. So, this option is wrong. Okay. It can resist the torsional forces. Absolutely right. In combination fractures, absolutely wrong. We have read multiple times that when there are more than one fracture in mandible, Champy's principles do not apply. Okay, Champy's principles apply only in cases of linear or single fractures of mandible. You cannot do a Champy's fixation in polytrauma, in multiple fractures, in comminuted fractures, in atrophic mandibles, in any special situations. You cannot fix with Champy's principles. Champy's mini plate fixation is a semi rigid or a functionally stable fixation which can be used only and only in linear fractures of mandible. Mandible. Midface, there are no rules. Just put a mini plate wherever there is a fracture. There are no rules in midface, zygoma, orbit, no rules. You can put a mini plate anywhere. All right. But in mandible, which is a mobile bone, you cannot use functionally stable fixation. You cannot use semi rigid fixation if there are combination fractures or if there are special situations like comminution, atrophic mandible, pathological fractures. You need a rigid fixation there, like a recon plate. It can act as a compression band. There is nothing like a compression band. Okay, there is a tension band which it acts like. It's called a tension band and not a compression band. So, correct answer for this question is it can provide a functionally stable fixation. Again, coming back to the notes where we have discussed the basics of fracture management, you have seen that fixation can be of two types. It can be external fixation, which is rarely used in maxillofacial cases. X-fix is most commonly used in orthopedic surgeries. The other thing which is commonly used in maxillofacial surgeries is internal fixation. Now, what are the methods with which you can do internal fixation? You can do a rigid fixation, a semi-rigid fixation, which is also called a functionally stable fixation. Non-rigid fixation is wrong. You do either a rigid or a semi-rigid. Okay. Again, coming back to notes where we have discussed mini plates in detail. Mini plates, semi-rigid. All right. Also known as functionally stable fixation. All right. So whenever we are using the Champy's principle, we always use mini plates, monocortical screws, and the kind of fixation that we get is not a rigid fixation, but a semi-rigid, which is acceptable functionally. All right. So in detail, I've put screenshots of the notes where we have discussed in detail. Okay. It can be used in whole face except for multiple fractures of the mandible. exact same line is asked in the exam. Okay, in the mandible, simple fracture, mini plate. More than one fracture, at least one recon plate should be fixed. So exact lines we have taught you, exact lines are asked in the exam. All right, so I hope all of you who have read the notes, who know the concept, you have marked correctly. All right, so this is how we fix a single mini plate in the superior border of mandible using mini plates and four monocortical screws. A few cases which I have shared with all of you. One extra thing which I will tell you, so that maybe if this is repeated in NEET in INI, you have a little more knowledge. So this is a transbuccal trocar cannula. This is a special instrument which is used especially for angle fractures of mandible. Okay, in cases where you're not able to put these screws, because whenever you do angle fracture treatment intraorally, if you're doing extraorally it is easy, you can put screws directly. But if you're doing the surgery intraorally via an intraoral incision, sometimes it becomes difficult to put these screws, these superior screws, it becomes difficult to put them. All right, even these screws sometimes it becomes difficult. So you can use this special instrument which is known as a transbuccal trocar and cannula. Okay, this is the way of using it. This is the uh, transbuccal trocar. You can drill through it, you can put screws through it, and this is how you can treat it. This is a case which I usually show in the class. First step in any fracture management for ORF is to do IMF. In this case, we have used the eyelet wiring to do an intermaxillary fixation. You can see in this OPG the angle fracture. You can see in this 3D CT also the angle fracture. It's a linear undisplaced fracture, so you can treat it very easily with the mini plate. And this is how you fix the mini plate. All right, just a little reflection of the lingual side. This is the lingual side. This is the buccal side. A slight reflection of the flap on the lingual side, and you can nicely put two screws. So it doesn't really damage the lingual nerve if you do it carefully. It's not a common complication to damage the lingual nerve while putting a mini plate there. All right, so this is how AO does it. This is how I have done it. This is how it looks on an OPG post operatively. This is how it looks on a CT post operatively. And this is how you actually fix a transbuccal trocar cannula. Because sometimes these ramus screws, it's very difficult to put them intraorally. So just put a small nick on the skin, put the trocar, put the cannula, drill through it, put the screws through it. And just a small half centimeter incision, you just put two nylon sutures and the scar is hidden. Okay, so this is the full case. Now you know this is how you fix it, and this is the correct answer for this question. Okay, coming to question number 5 very quickly. A radiographically diagnosed. This is one tricky question. Okay, this is a PYQ which is twisted. That is why it becomes tricky. Listen to the question very, very carefully. A radiographically diagnosed, it's not clinically diagnosed, not seen clinically. Okay, so whenever we see anything, whenever we see any disease or any pathology, first we see clinically, right? Then we do a radiograph. Correct? This case, this pathology is not seen clinically. An oroantral fistula, not seen clinically, diagnosed on a radiograph. Okay, because the patient presents with nasal pus discharge. Now, what would be the appropriate treatment for this case? I will show you all the things that we have taught in our note, but first understand the concept. This is the nasal septum. This is the turbinates in the lateral nasal wall. Okay. Attached to the lateral nasal wall is the maxillary sinus. Attached to the floor of the sinus is the oral cavity. Okay. This is the maxillary sinus. Right. Now, imagine this patient, he's got an extraction or something done. Okay, there is an oroantral fistula. Okay, but it is not seen intraorally. Okay, it has caused what it has caused? It has caused a sinus infection. Obviously, if there is communication of oral with sinus cavities, there will be infection. So it has caused sinus infection. Okay. Now, sinus, natural opening of the maxillary sinus is in the middle meatus. This is how it drains. Okay. So whenever there is infection in the sinus, whenever there is pus, it can drain from two parts. Either it can drain intraorally through the oral cavity, or it can drain into the nose through the nasal cavity. That's how we do an intranasal antrostomy, right? In this case, it is not draining orally. There is no oral drainage, which is why you cannot see the oroantral fistula clinically, right? Because नाक के अंदर से तो you can't see it, oral cavity say you are not able to see it. Okay, maybe because the oral epithelium, has healed. Okay, but the sinus infection is persisting. Okay, now radiographically you can see there is a breach in the bone. Bony breach is what you see on radiograph. Okay, so there is a bony breach, but the soft tissues of the oral cavity have probably healed, which is why you cannot clinically see this in the oral cavity. Because of the bony breach, there has been an infection in the sinus which is not settled. This infection is draining through the nasal cavity, causing a nasal discharge. Now, how will you treat it? Do you really need a flap here? Or all you need to do is just treat the sinus infection and give antibiotics, and that's it? That's the correct answer to this question. Okay, let us look at all the options. Antibiotics, yes, you should give antibiotics because it's a pus discharge. Excision of lining. Where is the lining? There is no clinical oroantral fistula. What will you excise? All right, so where will you excise the lining? Closure with local flap. Closure of what? You're not able to see it clinically. What you see radiographically is a bony breach. And what you treat the oral anterofistula is with a soft tissue. You don't treat it with a hard tissue. You don't reform the bone there. All you do is close it with a soft tissue. So you don't need this option. Okay. Second option and third option are to confuse you because they were there in the previous questions which were asked in the last few years. Acrylic plate. Arey, why? Why do you need an acrylic plate? There is no real clinical discharge from the oral cavity. So why? Okay. Acrylic plate, antibiotics, and expect spontaneous closure. You don't need it. Titanium mesh. Arey bapre. Titanium mesh for oroantral fistula we've never used. Titanium mesh is always used for orbital floor fractures. Okay. And after that, even if you use a titanium mesh, we give you that benefit of doubt. You use your titanium mesh, but you put a buccal flap and buccal fat plate closure where there is no fistula in the oral cavity, right? All you need to do is just clean the sinus. The residual sinus infection which is there, that needs to be treated. How will you do it? Before starting any antibiotic, any chronic infection, you have to take a pus culture so that if there is any resistant organism or if there is any fungal or tubercular growth, you can give antibiotics accordingly. So you take a pus culture, you do a sinus lavage. Instead of doing a fistula lining excavation, do a sinus excavation. Okay, how can you do it? You can do it in two ways. You can do it by open surgery or you can do it by a process called FES. Okay, functional endoscopic sinus surgery. You can do a lavage with FES, which usually the ENT people do. You can do it with that. And you start antibiotics, and that will cause a spontaneous closure of the fistula, of the discharge. Okay, so understand here, not all oroantral fistulas have oral problems. They can also have nasal problems. And in this case, there is a nasal problem. Screenshots from the notes where we have taught you this thing. Treatment sinus regimen. Okay. Temporary discontinuation between the oral and sinus cavities. In this case, there is no discontinuation clinically. So that A step is not required. Sinus regimen. Now, what is sinus regimen? sinus regimen for 5 to 7 days, antibiotics, analgesics, antihistaminics, decongestants, and steam inhalation. Only medically, if you need to treat it, these are the steps with which you will decongest the sinus. If with decongestion the treatment is not happening, if there is a chronic pus discharge, then you will need to do a physical curettage, which is through FES or even open surgery. All right, so this is how you will answer question number 5. Okay, I hope everything is clear. uh, Option for antibiotics was not given, 100% it was given. I have taken the exam, and I have taken the exam only and only for oral surgery questions. So 180 minutes, all I was doing was mugging up oral surgery questions. So I believe in the recall that I've done, and it is also confirmed with a lot of students. So do not think that the option was not correct. Definitely there was empirical antibiotics in the option, and it was there. All right, so don't worry about it. Okay, again, a very, very straightforward PYQ. I don't even think it needs discussion. A patient needs tooth extraction in a previously radiated area. Which of these is the biggest concern for this patient? Is all of them are concerns, okay? But the biggest concern is osteoradionecrosis. Delayed wound healing, yes, it will be there. Alveolar osteitis, yes, it can also be there. Fracture, yes, a pathological fracture can be there. But this is the best answer. This is the best answer, and you are always supposed to mark the best answer. All right, so this is the correct answer. We have discussed about Marange, which is the medicine related osteonecrosis of jaw. Initially it used to be called bronze and aronge and so many things. Basically it is medicine related osteonecrosis of jaw. We have discussed this in detail in the infections chapter. Most common drug is bisphosphonates. Other drugs, tyrosine kinase inhibitors, immunosuppressants, SERMs, monoclonal antibodies, and so many other drugs which can also cause MR-ONJ in a patient. Okay, so a non-healing, non-vascular hypoxic wound is the problem. What additionally can you do in such cases? You do an HBO therapy, which is the hyperbaric oxygen therapy. Dives are given. The patient is asked to go into a chamber for 90 minutes. It is similar to a person doing scuba diving. Okay, so when you do a scuba diving, you dive into the sea. You dive very deep. You dive so deep that the pressure is around 2.2 times the atmospheric pressure. It is so deep diving that the HBO therapy chamber has the same pressure. That is why every sitting of HBO therapy, we call it dives, similar to a scuba diver diving into the sea. Okay, so every session of HBO therapy, you are given some dives before extraction, you are given some dives after extraction. We follow the Marks protocol, which is there in the notes, and you can all go through it. For HBO therapy, there are certain contraindications which you have to be really careful about. Please go through it. Apart from HBO therapy, you also use a drug called pentoxifylline. Okay, now these are all INI based questions. Why I am telling you specifically is because INI is coming up, and INI is maybe will not ask you very easy questions. So remember, pentoxifylline is one drug which is used in such cases whenever there is a vascular compromise. Okay, whenever there is a vascular compromise. Okay, so in free flaps also, when we are doing a free fibula flap and we are putting it on the mandible, we feel there is a venous thrombosis, there is a congestion, you give pentoxifylline. Okay, so whenever there's a vascular compromise, you give pentoxifylline. And along with HBO therapy, you give tocopherols. You give tocopherol, which is the medical name for vitamin E. Okay, this helps to prevent oxygen seizures or the oxygen induced free radical injury in a patient undergoing HBO therapy. All right, so these are the two additional facts which I've told you. Remember, it can come in INI and these facts can be asked. So these are the important facts. Just some notes showing you how in detail we have discussed the previous year questions. And hypoxic, hypocellular, hypovascular in an irradiated bone is what effect is due to the end arthritis of small vessels. So discussed everything as PYQs, also discussed everything in notes also. Uh, a patient with mandibular angle fractures comes with infection. Which of these bacteria is responsible for this infection? Now, again, the best answer for this question is Staphylococcus aureus. Okay, Angle fracture with infection is going towards, infected fractures and sometimes osteomyelitis. It's a little controversial because some of you may feel that, alpha hemolytic streptococci is also the answer in a lot of books. Okay, a lot of books mention that, normally osteomyelitis of long bones is caused by staph aureus, but osteomyelitis and mandible more commonly caused by alpha hemolytic streptococci. That is what we have taught you also. But since the question is not asking about osteomyelitis per se, it is just asking you that a simple mandibular angle fracture is infected. Okay, so which is the most common organism? It has to be staph. Okay, any oral infection, first organism, it has to be staph. Okay, so this should be the best answer is what I feel for this question. Vazirani Akinosi nerve block is given for which of the following indications? Pulse synopsis, it is given as initial excitement followed by depression. I cannot be responsible for pulse synopsis. I am telling you exact lines from Malamute. Okay, exact lines from a standard textbook, which is the standard which we should all follow. All right. Vazirani Akinosi nerve block is given for which of the following indications? Again, a very straightforward question. It is given for trismus. In cases of trismus, it is a closed mouth mandibular nerve block. All right. So whenever there is imagine there is a patient of pterygomandibular space infection and you have to extract a molar. Because of the pterygomandibular space infection, the patient will not be able to open the mouth. In such cases, how will you give an inferior alveolar nerve block? In such cases, you will do a Vazirani Akinosi mandibular nerve block. Okay. Obviously, we have taught you in the notes. It is there. It is a closed mouth technique. Patient is unable to open the mouth. Okay. And straightforward question. Okay. This is, I think this is the last question. Okay. Second last question. Which of these is correct regarding the use of CPAP in the case of OSA? This is a difficult question. This is definitely a difficult question because in this much depth, usually it is not being taught anywhere. So this is one of the difficult questions in oral surgery. Let me tell you the correct answer. The correct answer is D. Okay. CPAP causes increase in air pressure of throat during sleep. No, that is not the mechanism of action of CPAP. It just creates a patency in the airway during the sleep. So option B is partially correct. But option B also has only when it is used with an oral appliance. So this makes option B wrong. Okay. The actual mechanism of action of CPAP in option B is correct. But option B also has only when used with an oral appliance. No, this is wrong. So that makes option B also wrong. CPAP is primarily indicated in cases of OSA needing invasive treatment. Absolutely wrong. CPAP is only used for mild to moderate cases of OSA. CPAP or oral appliances can never be used in severe cases which need invasive treatment. In such cases, the CPAP will not work. Okay, which is the correct option? Option D. CPAP is not an effective modality in cases of severe OSA. Okay, we have discussed in detail what is OSA, what are the different sleep disorders, what are the types of apnea, then what is obstructive sleep apnea. Understand this. Okay, obstructive sleep apnea is when during the sleep there is some obstruction in your airway. Okay, now it can be anything. It can be due to micrognathia, retrognathia. It can be due to a mandible which is hypoplastic. It can be due to anywhere in the respiratory tract. It can be a nasal polyp. It can be a deviated nasal septum. It can be the nasopharynx which has a tumor. It can be the oropharynx which has a tumor or a cyst or some aneurysm. It can be in the lower airway near the epiglottis. So at any stage, at any point in the airway, if there is an obstruction, it can cause an obstructive sleep apnea. So these are the anatomical or the direct factors causing OSA. Other than that, there are also certain non-anatomical risk factors like obesity. A person with a very, very, wide bull neck, lot of fat around the neck, that also contributes to obstructive sleep apnea. Advanced age, male gender, pregnancy, all these things are the non anatomical factors which contribute to the severity of OSA. Miscellaneous factors like alcoholics, smokers, people who are on sedatives and anti hypnotics, such kind of drugs, there in them also there is chances of sleep apnea. Now, how do we know what treatment should be done in what case? Okay, so these are the management things. Lifestyle changes to correct things like the obesity and smoking and all those things, and positive airway pressure therapy like the BiPAP and CPAP, oral appliances like the MAD, which is the mandibular advancement appliances, and in the end, you will do the surgery if it is severe. Like if there is adenoids which is causing enlarged adenoids, enlarged tonsils, which is causing sleep apnea, you will remove the adenoids, which is the most common cause in children with OSA. Okay, if there is a macroglossia, you will get the tongue resection like Mr. Arvind Kejriwal has got it done. If there is a micrognathia causing retruded mandible, like in Perry Robin sequence, you will do a distraction of mandible and you will bring the mandible advance, you will bring the mandible forward. So, whatever is the cause of obstructive sleep apnea, that cause can be removed by, if it is not being treated by other medical management, then you have to do surgery. Okay, and remember the CPAP, BiPAP, oral appliances, these are only used in mild to moderate cases of OSA. They will not have any effect on severe cases of obstructive sleep apnea, which makes the option D the correct option. All right. So it's okay if you guys have left it. It's okay if you have not marked it. It was a difficult question, and congratulations to all those who have answered it correctly. Okay. Next question. Uh, a patient with nasal congestion, discharge, and nasal bleeding since the last 2 months. There is also a history of spontaneous exfoliation of the upper molar. This is the biggest hint in the question. Okay, spontaneous exfoliation of teeth, floating teeth, limited conditions in which you will have this: malignancy, osteomyelitis, cherubism in maxillofacial region, and sometimes in a central vascular lesion. These are the only four conditions which will cause all the bone around the tooth to resorb. So in the x-ray, either you will see the tooth is floating, or that floating tooth is also exfoliated spontaneously. So these are the only four reasons of spontaneous exfoliation of teeth. And in this maxillary sinus adenoma, it's a benign tumor. Adenoma, we know it is benign. Maxillary sinus malignancy, yes, that is a malignancy. Chronic maxillary sinusitis, it means there is inflammation in the lining of the maxillary sinus. So that will never be so severe that it causes so much resorption that the teeth will only fall down. Okay, unless it goes into osteomyelitis. If this goes into osteomyelitis, yes, it can cause the tooth to fall, but osteomyelitis is not mentioned. Tubercular sinusitis, again, it's an infection, doesn't really involve the bone. So the correct answer for this question is maxillary sinus malignancy. Okay, you can see here again, this is the maxillary sinus. This is the kind of image we drew in the last question. So this is the nasal septum, this is the turbinate, lower turbinate, middle turbinate, this is the ostium through which the sinus drains. Okay, there is infection or there is malignancy in the maxillary sinus. So again, in this question, there is nasal congestion, nasal discharge, nasal bleeding. So instead of an oral communication, in this case also there is more of nasal symptoms. Everything is coming out nasally, and slowly it is expanding to involve the maxillary alveolus and causing the tooth to exfoliate spontaneously. Okay, so that is how you have to answer this question. Coming to the next question, again a case of Ludwig's angina. A patient presents with severe submandibular swelling. Now, Here, very indirectly, they have told you that it is Ludwig's angina. Okay. Severe submandibular swelling. That is the first hint. Trismus and raised floor of the mouth. Okay. CT reveals cellulitis, severe cellulitis. So the definition of Ludwig's angina is that it is a severe cellulitis with flecks of pus. Okay, now it is going slowly, slowly, it will go into abscess stage, but currently it is a severe cellulitic phase. And we all know that the first step in management of Ludwig's angina is airway management. That is the first step. Before you do an incision and drainage, before you do a pus culture, before you start antibiotic therapy, the first step is an airway management. And in such severe case, when there is trismus, you can't do oral intubation. Raised floor of the mouth, you can't do any normal intubation. The only option in such cases is the surgical airway. And the surgical airway means either tracheostomy or cricothyroidotomy. Crico is a temporary procedure, a more permanent procedure is tracheostomy. All right. With case discussion, we have discussed this in our class. We have discussed the case where first you will do a tracheostomy, then you will do a drainage of all the three spaces: bilateral, submandibular, submental, and sublingual spaces. You can see how the tongue is out because of the raise of the floor of the mouth. The swelling is so severe that the tongue is not able to fit into the mouth, it is coming out. Okay. And in Ludwig's angina, even in the notes, we know that it is a surgical emergency. Airway establishment is primary. Surgical intubation, tracheostomy. Direct pick from the notes. You can see how nicely it is there in the notes. Okay. And the first choice of airway establishment is the primary thing. Okay. Any management of space infection, first you need airway security. Okay. So tracheostomy is the correct answer to this question. And this brings us to the end of oral surgery questions discussion. If there is any doubt or anything which you guys want to discuss, we still have 1 minute. I'll wait if you have any doubts. Maybe the examiner is asking about behavioral excitation followed by depression. See, that words are not there, beta. In the question, the words are.
Hello, good afternoon, everybody. Just type it in the chat box that I'm audible and visible to everybody so that I can start with the recall. Okay, I can see some messages. All right, all right. Okay, so good afternoon, everybody. I hope your exam went well. And I heard that OMR was easy. So, what is your opinion? How was the OMR paper? How was the OMR paper? I heard that it was easiest. So, I want to know that you guys have attempted all the OMR questions. Okay, easy. I can see some. All right, I am very happy for you all. So let us start with the recall session of OMR. All right. Uh, First question that you had. So we have collected these questions based on the like recall by the student. So if you can correct some options or you can add some important points to the questions, you can in the chat box. Okay. So based on our recall, we are going to be starting with the OMR recall. All right. So first question was, which of the following has the maximum malignant potential? Okay, which of the following has the maximum malignant potential? This question was asked about like 50 to 60 times in the group telegram groups. We have been revising this since our live classes. You must be seeing this in the recorded classes also for DBMCI students, of course. All right. So what should be the answer for this question? Which of the following has the maximum malignant potential? So this I have been telling you all the sequence of the malignant potential since the 1 year, right? So PVL, proliferative varicose leukoplaskia has highest malignant potential. Then we had this erythroplakia in the line, correct? Erythroplakia in the line. Then we had heterogeneous leukoplaskia, and the last one is homogeneous leukoplaskia, correct? This was so easy, direct pick, correct? So direct pick from our notes, DBMCI notes, correct? So this we have been studying since our classes, correct? So this is easy question. So option number A is the correct answer for question number 1. Correct? This was easy. Then, second question. This is also direct pick, easy question based on syndrome. Correct? A patient with lower lip edema, facial paralysis, and fissured tongue present with this. Uh, these are the features that they have given. Okay, the three features: lower lip edema, facial paralysis, and fissured tongue. Okay, they are just asking in which syndrome do you see all of these features. Correct? This also is, you can say, the direct pick from the textbook or in our DBMCI notes, okay, from our DBMCI notes. And the easy answer for these three features, you can see it in the Mulkerson-Rosenthal syndrome, option number C, correct? This is also a direct question. Just three features are given. They are just asking you which syndrome shows these features, correct? And if I show you this notes, correct? This is our OMR DBMCI notes. And we have this direct pick from the notes, correct? These features of Mulkerson-Rosenthal syndrome, and we have studied the topic of fissured tongue. Okay, fissured tongue. Can you see this picture? Okay, so I will be telling for the students who will be giving the exam in next year, like 2026. Okay, NEET MDS 2026. So for you guys, they might give you the picture, okay, fissured tongue picture and other two pictures, and they will give you in which syndrome do you see these features. Okay, so IBQ based question can be asked in next year. Okay, this year of course they have directly given the features and they have asked about the syndrome name, correct? So this is also easy pick, deep features on the tongue. All right. And the other features are facial palsy, hypoplasia of salivary gland, and swelling of face and lips. Correct? This is also a direct question, and the answer is option C, Mulkerson-Rosenthal syndrome. Okay. Next question that we had. See, this is also a direct question. They have just given the features of the syndrome and they are asking you in which syndrome do you see this. Okay, so first, a patient with bird-like face, micrognathia, small sized jaw, comes with a cleft palate. Okay, cleft palate is also a feature. And then the glossoptosis ka meaning we have seen, there is a downward placement of tongue, and this tongue might obstruct the airway. Okay, this is the glossoptosis condition. Okay, and this occurs, glossoptosis condition occurs due to micrognathia, that is small sized jaw. Okay, small sized jaw, due to small sized jaw, tongue is placed downward in downward position. Okay, and it might restrict the airway. All right, and this question also we have taken in YouTube session. Okay, this was the YouTube session 6 months ago. Most important topics. Okay, and I've taken this topic also. P. Robinson syndrome. Okay, the three features that they have given in the question. Okay, what should be the answer here? B. Yes, I can see many correct options here marked by you guys. Okay, very well done. Pete Robbins syndrome is the correct answer for question number 3. All right. Chalo. Next question that we have. Okay. A 32 years old female patient with a history of tobacco chewing since 14 years of age comes with a reduced mouth opening. On examination, there were no ulcers. Okay, what is the diagnosis? Now here they have given the history of tobacco. Okay, so what are the features? What are the clues that we have here? History of tobacco chewing. Okay. Second clue, reduced mouth opening. Reduced mouth opening. Okay. And there were no ulcers as such. There were no ulcers as such. Okay. So, by just looking at this feature, reduced mouth opening, okay, many of you will get the correct answer. Okay. Many of you will mark the correct answer. Okay. So, OSMF, we have seen it is an inflammatory condition, correct? And it mainly occurs due to areca nut chewing, correct? Areca nut chewing. So they might replace the word tobacco with the areca nut. If they would have given directly areca nut, then we would have marked OSMF. Okay, directly OSMF by just looking at the areca nut chewing and reduced mouth opening. Okay, but here I will be telling you the difference between option A and D, carcinoma of buccal mucosa and the OSMF. Okay, lichen planus to ruled out, correct? There is no reduced mouth opening in lichen planus. There are vicum striae in lichen planus, also burning sensation. Okay, so none of the feature is given in the question, so lichen planus is ruled out. Second is oral thrush. Oral thrush is candidiasis, correct? Candidiasis के लिए भी we need two features: burning sensation as well as scrapable lesion, white milky curd like white lesion, correct? So there is no features of oral thrush or candidiasis in the question. Okay, so these two ruled out automatically, correct? So we have two options left. Now, in carcinoma of buccal mucosa, yes, there can be a reduced mouth opening. There can be a reduced mouth opening due to invasion. Okay, invasion of cells, cancer cells, correct? But carcinoma of buccal mucosa is ruled out when they give us there are no oral ulcers. Okay, if they would have given here there is a ulcerative growth, ulceroproliferative growth on the cheek region, okay, and then the reduced mouth opening and then the history of tobacco, then the answer would have been option number D, correct? Carcinoma of buccal mucosa. But since they have given there are no oral ulcer, the most probable answer for the question number 4 is option A, OSMF. Okay, OSMF. They would have given some more features. to confirm the diagnosis of OSMF. Okay, but still, the most priority you should give it to option number A. Okay, so the correct option for this is OSMF. Okay, yeah. I hope you all have marked the correct answer. Okay. OSMF also we have studied in the live classes, in the recorded classes, in the notes we have the OSMF topic dedicated. Okay. So for the students who will be giving exam next year, please remember this OSMF. They might modify the same question, they will add some features, they will give you some treatment plans also. Okay, so they can modify this question and give you next year. Okay, because there are many PYQs that were there in this year also. Okay, so you people have to go through these all questions. They can just modify these and give you next year also. Okay, so OSMF के लिए we have this main component, or you can say the content of tobacco or areca nut is arecolin and tannin. Okay, these two are the important components that increases the collagen deposition. Okay, collagen deposition increases, and then the features, clinical features that you see in OSMF, you can see like blanching of oral mucosa. So blanching will cause the all over the decreased vascularity. Okay, what is the main cause of blanching? It is decreased vascularity due to increased collagen production, right? So blanching, and in more severe cases, you have reduced mouth opening, hockey stick shaped uvula. Okay, there will be some vesicles and ulcers in severe cases. Okay, in the fourth stage. All right. So this is about the OSMF. Okay, that you need to remember. And treatment plan also, we have studied treatment plan for OSMF. Treatment plan for OSMF, capsule lycopene, antioxidants we give intralesional steroids, intralesional injections on multiple sites, correct? So this we have studied, and I am happy that you guys have marked it correct. All right. Chalo, moving on to the next question, question number fifth. Okay. This is also a direct question, but they have given the histological options, or you can say histological features in the options. Okay. So Kuttner's tumor, what is Kuttner's tumor exactly? The synonym for Kuttner's tumor is chronic sclerosing sialadenitis. Correct? Chronic sclerosis sialadenitis. This is the synonym given in the textbooks. But what do you see histologically? Okay. Chronic sclerosing sialadenitis, meaning what? This is just a benign inflammatory enlargement of salivary gland. Inflammatory enlargement of salivary gland, correct? Now, the salivary gland, if you can say the gland, salivary gland will show firm, painless, and slow growing mass. Slow growing mass. Okay, so Kuttner's tumor is basically a benign, you can say inflammatory enlargement of salivary gland. Okay, the salivary gland will show firm, painless, and slow growing mass. Okay, so it is just an inflammatory condition, but what happens here is there will be silometaplasia of submandibular gland. Okay, so what is the correct answer here? Option number A is the correct answer. It is silometaplasia of submandibular salivary gland. Okay, what exactly happens in silometaplasia? It is just a duct epithelial ductal epithelial metaplasia due to inflammation. Okay, due to inflammation, what happens is the ductal epithelium shows metaplasia. Okay, and just they have given the synonym, but in the histological variant. So it is nothing but a silometaplasia of submandibular salivary gland. Option A is the correct answer here. Okay, I hope uh, mm, all of you have got the correct answers here. Okay. Okay. Chalo. Now moving on to the question number 6. Just a second. I think I have missed one. Hmm. Okay. So this is the next question. A 23 years old boy comes to you with a pain and swelling in the floor of mouth. Okay. The pain increases on taking meals. Radiograph reveals radiopaque mass in the submandibular salivary duct. Which of this is the diagnosis? This is the exact PYQ we have solved. We have solved it in the GTs, PCTs, okay, live classes. We have discussed this, correct? Very easy, very direct question. And yeah, of course, those who have studied will get the correct option, okay? And we have seen this. What should be the correct answer here? What is the correct answer here? It is silolithiasis. It is silolithiasis, correct? When there is a silolith in the duct, okay? When there is a silolith in the duct, what happens is when the patient have meals or eat food, okay, he will have a transient pain and swelling in the salivary gland, correct? Okay, because the silolith will obstruct the salivary flow, correct? Silolith will obstruct the salivary flow, and that is why the patient will have a pain and swelling in the gland. Okay, when you take a occlusal radiograph here, when you take a occlusal radiograph, okay, you will see something like this. Okay, yeah. So when you take a occlusal radiograph, okay, you see something like this in the occlusal radiograph. So in the Wharton's duct, you will see this radio opaque mass, okay, uniform radio opaque mass in the salivary duct, okay, and this is nothing but a silolith, okay, and the condition which is caused due to the silolith is silolithiasis, which is our answer in the question, okay. So this is also we have repeated multiple times, and we have put it in the GTs and PCTs, SWTs, everything, everywhere, okay. So DBMCI students, I hope you guys have marked the correct answer. Okay. See, in the notes also you will get these symptoms. Patient will have a dry mouth. Okay. If there is a complete blockage by the silolith, patient will have a transient pain. before meals, or okay, and the swelling will be there in the affected region. Correct? So this is about silolithiasis. Now, next question that we have here is this. Which of this is correct? Which of these is the correct distance of the X-ray source to the mid-sagittal plane of the patient during lateral ceph? Okay, so mid-sagittal plane, which divides the face into two halves, equal halves, correct? So this is the mid-sagittal plane that we have. They are just asking the distance between mid-sagittal plane and the X-ray source. Okay, now we have two distances here from the X-ray source to mid-sagittal plane and from mid-sagittal plane to the film or mid-sagittal plane to the film or receptors. Correct? Here they are asking from X-ray source to mid-sagittal plane. Okay, the distance between X-ray source and mid-sagittal plane is 5 feet. 5 feet. Okay, that is 60 inches. So the people who have marked 5 feet are correct. Option A is the correct. Okay, and the students who will give exam next year, please remember the other distance also from mid-sagittal plane to the film or the receptor. The distance is 15 centimeter or 6 inches. 15 centimeters or 6 inches. Okay, so 5 feet is the correct answer. Well done, everybody. Chalo. Next is also very easy, very direct pick from the notes. We have seen it multiple times. I have solved the doubts in the telegrams. Okay. So a patient comes with a suspected zygomatic arch injury. Which of the radiograph would you do to come to the diagnosis? Okay. A, PNS view. B, SMV view. C, reverse Towns view. D, we don't know. Okay. If anybody can recall, please do that. Okay. So zygomatic arch injury. We have seen it. I have given you guys on the last day the points to remember, last minute revision. There also we had revised the list of the radiographs indicated for each structure. Correct? So here the ideal answer should be jug handle. Correct? Jug handle view. The ideal answer should be jug handle view. है ना? But since Jagandal view was not there, we have other correct answer for it. It is SMV view, which is submento vertex view. Okay, jug handle view is just a modification of submento vertex. Correct? So if you have submento vertex and jug handle both in the option, you will go with jug handle. Okay, but since it is not there, we will mark SMV, submento vertex view, as a correct answer. Okay, next question. Yeah, this I put the screenshot of the notes here. Submento vertex, we have seen submento vertex or jug handle, which is a modification. We have seen for what structures these both views are indicated, correct? And we had seen the radiographs also here. This is jug handle view. This is SMV view. Okay. So next question here is 55 years old male patient presents with a pain and swelling in the lower jaw. Okay. On the clinical examination, left angle and body were tender with mild buccolingual expansion of cortical plates. OPG revealed this. Okay. So this is a tentative OPG that I've taken. Okay, we don't know the exact OPG image, but yeah, according to the recall from students, we have taken this OPG. Okay, so pain and swelling in the lower jaw. Okay, there is mild buccolingual expansion. Mild buccolingual expansion. I can say this is the only clue that they have given here, and the other clue is your OPG, correct? So you have to diagnose the condition based on your radiographic interpretation, correct? Radiographic interpretation, and this, you can see this scalloped margin, okay, scalloped margin in the left side, left body, and extending till the ramus. But what is the, you can say, the characteristic feature that you see in this radiograph is anteroposterior expansion. Anteroposterior expansion, correct? There is no, as such, expansion of the inferior border of mandible. Okay, so characteristic feature of anteroposterior expansion is for option number D, which is odontogenic keratocyst. Okay, if there would have been a complete, or you can say, expansion of inferior cortical border, okay, or they would have been given buccolingual expansion, not mild, okay, severe buccolingual expansion of cortical plates, then we would have gone with the ameloblastoma here, okay. But there is a mild buccolingual expansion, and in the OPG, we have anteroposterior expansion, okay, anteroposterior expansion. So the answer, the most probable answer for this question is odontogenic keratocyst. Okay, so dentiger assist, uh, if they would have given dentiger assist in the option, and I'll just tell you the features. If they would have given dentigerous cyst in the option, and we have this OPG image, and there would have been a impacted tooth over here, and then the radiolucency, then the expansion, little expansion over here, then the answer would have been a dentigerous cyst. But there is no impacted tooth. Okay, there is an anteroposterior expansion given. That is a characteristic feature of OKC. So here we will go with the OKC. Okay, ameloblastoma maybe you have the severe expansion of buccal and lingual cortical plates. Also, inferior cortical plates is expanded. Okay, so according to the given features and the recall from students, we will go with the option number D. Okay. Um. So yeah, I can see some. Okay, ameloblastoma was not there. Okay, it's okay. Ameloblastoma not there. It's okay. We are going with OKC. OKC was there for sure. OKC was there in the option. Okay, and according to the recall from students, okay, I would be going with the OKC. Okay, chalo. So OKC also we have studied. Okay, this is a screenshot from notes. We have scallop border, which is given in the OPG, anteroposterior expansion, which is given aggressive. OKC is aggressive, okay? And there is a root resorption associated. So if they will modify the question and give you next year, please remember the other feature also, okay? Which tells you the OKC as a correct answer, okay? Now, next question, name the X-ray view. Name the X-ray view. So there was the X-ray view. Some are telling there were angulation of 30 degree, some were telling there was angulation of 45-degree. Okay, so we have just put it. But here the X-ray that you can see here is the reverse towns view. Okay, reverse towns view. So if you people have revised the DBMCI notes and have gone through the extraoral projections or radiographs, okay, they would have marked the correct answer, because I have given the positioning of the radiograph also, the positioning of the patient also, and I have put the radiograph also in the notes. Okay, and we have in the live class also we have studied about this. All right, so if we look at this notes ka positioning, okay, for reverse towns, the patient's forehead touches the film or the receptor, correct? And it forms angulation of 30 degree with the film. Okay. The canthomeatal line forms the angulation of 30 degree. Correct. Now, the radiograph that you see here is this. And what important structure you can see in this reverse towns is high condylar neck. Correct. So reverse towns is the view or radiograph which is indicated for fracture of high condylar neck. Correct. So they might modify the question as high condylar neck fracture is seen in which radiograph, or which radiograph is indicated for high condylar neck. So they can modify this question and give you. So here in this exam, they had given the radiograph and the positioning. Okay, based on this, you will have to you had to identify the option. Okay, correct option. So here I will go with the option number B, which is reverse town's view. All right. Okay. So basically, this is just a recall. This is not the. I just want to tell you, this is not the exact paper. Okay, we cannot recall the exact paper and the exact images, but this is the idea. Okay. Uh, about how question was asked and how you should um, um, solve these kind of questions. Okay, so yeah, so these are some questions from OMR, and I hope you guys have got it correct. Okay, because these were very easy and the direct pick from the textbooks or notes. Okay, so what is important for the students who will be giving exam in next year is you will have to have attend the GTs, PCTs, every session that we conduct on the YouTube. Okay, and be thorough with your notes. Okay, then you can solve and you can approach the questions which will be asked next year. Okay, so yeah. Any suggestions, any you can say any more questions you want to recall, you can put it in the Telegram, or we have dedicated WhatsApp group for the recall, so you can put it there. Okay, and thank you so much, and the next session will be continued by Dr. Kunal sir.
Hi, Dr. Priyanka. How are you? So I hope students must have got the maximum right answers in your subject. I also hope the same thing for my subject as well. Hi, Dr. Priyanka. How are you? So I hope students must have got the maximum right answers in your subject. I also hope the same thing for my subject as well. All right. Good afternoon, students. Good afternoon, everyone. So now you are here done and dusted done and dusted by the NEET 2025 exam. So I hope, how was the exam? I hope the exam was good. Yesterday, I had talked to a few students, around 6 or 7 students, yesterday evening around 8 o'clock somewhere. So I got a mixed review about the difficulty level of the question as compared to the last year question paper. And personally, what I think, this year paper was relatively easier than it was last year. Especially I'm talking about the orthodontic part. Okay. So how was the exam? I want to have your feedback, students. Please, if anybody can write in the chat box. I am right here at the in the YouTube live session. So whatever questions, whatever feedback you want to give, you can give it right now. I'll be able to see them. And since it's a recall session, it is possible that all of the options, all of the questions are not exactly the way they were asked in the exam yesterday. There could be some differences, there could be some missing options, or there could be some all different options altogether. So I want your support, I want your cooperation also in case any option is missing. So you can provide right here, right now. We can modify the question, we can modify that answer. And okay, so let's start with the session. So the first question which was asked in the exam yesterday was the percentage of incisor visibility in relation to clinical crown height is called as smile index, smile arc, Bolton's ratio, or Morley's ratio. Now, this was an easy question. We have talked about it in the live lectures, in the as well as in the notes. Also, you already have this with you in one of the live lectures, recorded lectures. I think in some GTs or some live YouTube session also we have covered this topic. So, how an orthodontist looks at the different the different dimensions of the face, they fall into three categories: macro aesthetics, mini aesthetics, and micro aesthetics. So macro aesthetics means the relationship of the upper third, middle third, and the lower third of the face in the vertical and transverse planes of space. The mini aesthetics means the relationship of the teeth with the gums, with the smile, with the middle third of the face, that is mini aesthetics. And microaesthetics means the relationship of the dimension of the teeth, the transverse dimension, the vertical dimension in respect to the gums and the intercommissural width. So that falls under microaesthetics. Okay. So smile index. What is smile index? We have seen this slide earlier in the live and recorded lectures. The smile index is determined by dividing the intercommissural width by the interlabial gap during the social smile. Now, what is a social smile? Social smile is the one the patients or anybody, you, me, anyone, who smile in front of a social gathering. I mean, there are two types of smile basically. That's an enjoyment smile, like when the patient is fully happy. There's a dopamine rush in the brain, right? So that kind of a smile, that kind of a laughter rather, which reaches the eyes, that is called enjoyment smile. Whereas the other type of smile is called as social smile. It's also called as posed smile. We are posing it for the camera. It's also called as Duchenne smile. So how a patient smiles in front of a social gathering, or how the patient smiles when the orthodontist is clicking photographs, pre-treatment records or post-treatment records, how they are smiling for the camera. So that is called pose smile. The patient are giving a pose, right? So the smile index is determined by dividing the intercommissural width by the interlabial gap during social smile. That is smile index. Now the question asks the percentage of incisor visibility in relation to clinical crown height. That is called Morley's ratio. What is Morley's ratio? It depicts a percentage of incisor shown post smile with respect to the clinical crown height. The average ratio is 75 to 100%, whereas a greater Morley ratio would necessitate appropriate measures to decrease the incisor show. Now, basically, Morley's ratio is a mathematical index, or rather, it's a parameter to judge the attractiveness of a smile of a patient while the patient is giving a post smile for the camera. How is it measured? It is measured by measuring the by measuring the percentage of incisors show on post smile with respect to the clinical crown height. Like how much the tooth is visible while smiling, that much amount is divided by the total height of the tooth, the cervico-incisal height of the tooth, that is measured. So the ratio 75 to 100% means it's an attractive smile. Anything more or less, we have to change the position of the teeth accordingly. Okay? So the correct answer should be Morley's ratio. So what is smile arc? Again, smile arc, there are two types of smile arc, consonant and non-consonant. Now, smile arc is the curvature. It's a curvature of the lower lip. You can see here the yellow colored line of the lower lip in the first figure. How well it is flowing from the premolar to the premolar, the two teeth which are visible on the wide smile. If the incisal edges of these 8 teeth from the first premolar to the first premolar on the opposite side, if the incisal edges of these 8 teeth measure or they form a continuous line with the vermilion border of the lower lip, that is called consonant smile arc. Whereas in the second case, you can see the curvature is not proper. The curvature is not proper. That is called non-consonant smile arc, or it is also, and there's one more, there's a reverse smile arc. The relationship is exactly opposite to the consonant smile arc. So that is called reverse smile arc. And Bolton's ratio, you already know. It is done for model analysis when the mesodistal width of the upper and the lower teeth is measured together. A proper percentage value is established, and then we have to determine what is the amount of irregularity present. According to that, what is the amount of tooth material excess, overall tooth material excess, anterior tooth material excess, that is in relation to the model analysis. So the correct answer here will be Morley's ratio. Now, how many of you got it right? How many of you got it right yesterday? Please let me know in the chat box. Next question, the improved version of beta. I don't know what this question was. I couldn't recall. I couldn't get the complete version of this question. So I want you to help me out in this, because I couldn't get the complete question nor the complete options. So if anybody can help me out in framing the right answer or the right question, I'll be really helpful for you. Third question, in the Profit and Ackerman classification of malocclusion, the circles 3, 4, and 5 represent which of these? Now, this was an image-based question. And I think the image which is shown on the screen, this is the same image, or it's more or less the same image which was asked in the exam yesterday. Am I right? Or if you want me to correct it, you can correct it here. One second. Florence is saying super cable option is there in what? In which question, bache? Dual flex wire, super cable. That was a different question. Different question altogether. We'll come back to. I think the question was which of the following is a newer version of beta titanium wire? Is that what you were asking? I think that's the options for that particular question. Yeah, improved version of beta TMA wire. Okay, fine. Okay. Now, coming back to the third question. In the Profit and Ackerman classification, the circle 3, 4, 5 represent which of these? Now, we have studied Profit and Ackerman classification in the notes. We have studied multiple times in the live lecture, in the recorded lecture, and I mentioned it specifically that this classification, Profit and Ackerman classification, is one of the most important classifications used today in today's system of classification of malocclusion. So it should have been by heart for you. Okay. Okay, I'll come back to this. Justin is saying another question was that the length of the lower face is measured in Harvard analysis using. It's not length of the lower face. The question was asking the length of the mandible. I have that question also. I'll come to the question later. So this particular question, improved version of beta, I couldn't recall. So I want you to answer me. I want you to help me out in framing that question properly. Now we have studied in the notes. This is the Ackermann profit classification. It is divided into different groups. The first outermost envelope stands for alignment. I think there were 2-3 questions based on this particular diagram. So the first outermost envelope or the first square stands for alignment, intra-arch alignment. The first circle or the second envelope or the first circle, it stands for profile. How the profile of the patient is it anteriorly divergent, posteriorly divergent, concave, convex, or straight profile? Then the third group is called transverse deviation. Fourth is called sagittal deviation. Fifth is called vertical deviation. This is not a proper diagram. So the fifth is called vertical deviation. So the way how we go from outside to inside, that is centripetally, we go from outside to inside centripetally, the complexity of malocclusion increases. That's what it means basically. Okay, we have studied that in the notes, in the live lectures also, right? So group 9 is the most difficult malocclusion to treat. As I said, as we go from outside to inside, the complexity of treatment of malocclusion increases proportionately, rather exponentially, I would say. So it is clearly mentioned in the notes. Outermost square or the outermost envelope, it stands for alignment, whereas the outermost circle stands for profile, and outermost envelope is the easiest to treat also. So what should be the answer? 1 stands for transverse, 2 stands for sagittal, and 3 stands for vertical deviation. So option A should be correct in this particular case. One second. Florence is saying there was no question like this, sir. Which question are you talking about, Florence? Yes, only one question beta testing. Yes, sir. In one question, post smile was mentioned. Okay. Saurav, as I said, Saurav is saying there are wrong recalls. I told you in the beginning of the session, there could be some mistakes in the recall because it was a subjective recall and only few people participated in getting the recall question right. So I want your cooperation, Saurav and rest of the people, in recalling the proper language of the question, proper options right now. Okay. I had mentioned it in the beginning of the session as a disclaimer. All right. Now, Ackermann profit classification. Again, there was one more question on the same. The first criteria is what? The first criteria is what? So, we have seen that the first criteria, this is what it is. As we go from outside to inside, we have intra-arch alignment, we have profile, we have transverse deviation, group 3, group 4 is sagittal deviation, then group 5 is vertical deviation, group 6 is trans-sagittal alignment, group 7 is sagittal vertical alignment, group 8 is vertical transverse alignment, and group 9 is a combination of all alignment, that is trans-sagittal vertical alignment, that is the most complex to treat. Okay, so first, what should be the correct answer? Ackermann profit classification, the first criteria is, I would say, out of the options, if alignment was not given as an option, I will select none of the above because it is alignment. It is intra-arch alignment. That is why we will select none of the above. Okay. Florence is again asking me in the first question, you said answer is Morley's ratio, but post smile was mentioned. So answer will be no, it will not be smile index. I told you whether it is post smile or whether it is enjoyment smile, the answer will remain the same. That is Morley's ratio. Okay, it is not smile index. Okay, so Rupinder, Dentist Life, Rain, They are saying the fourth option was alignment. If this was alignment as an option, then alignment will be the correct answer. Okay. Ackermann profit classification. This is an important topic. So it should be by heart for you, by heart to you till now. Now, this is a refined or updated Ackermann profit classification represented in the form of a Venn diagram. Again, we have the outermost envelope as a dentofacial appearance. It can be asymmetric or symmetric. Then the outermost circle or the second envelope stands for profile. It could be concave, convex, or straight profile. We talk about the soft tissue also, soft tissue lips also, which can be classified as protrusive, normal, or retrusive. And we also talk about incisor display as excessive, normal, or inadequate. Then we go inside. The third is transverse deviation. Like we have to decide whether the patient is having deviation in the transverse dimension of the maxilla or the mandible. Then fourth is sagittal. We can classify the malocclusion as class 2 or class 3 depending on the anteroposterior position of the jaws in the plane of space. And the fifth one is vertical. How the patient's jaws are oriented vertically in the vertical plane of space, whether it is deep bite, open bite, skeletal deep bite, dental deep bite, and so on. And the combination, this is sixth, this is seventh, this is eighth, and the innermost envelope is the ninth, which is the most complex to treat. So we have yaw, pitch, and roll. And finally, we have a combination of all of them. That is the most complex malocclusion in all planes of space. That is the group number 9. Okay. Okay. So does anyone know the answer for amelogenesis question? Bache, it is not of orthodontics. Okay, somewhere profile is being discussed as the right answer. Okay, according to new edition, profit interfacial profile is outermost. Outermost envelope is always alignment. Okay. All right. Now, next question is least modulus of elasticity is shown by least modulus of elasticity. Now, what is modulus of elasticity? It is denoted by a Greek letter called epsilon. Now, this is a characteristic of a particular material. Now, once we are talking about the different types of orthodontic material used for orthodontic arch wires, the property called modulus of elasticity holds much importance. Because you see, different types of materials are used for making orthodontic arch wires, and each material has its own importance, has its own indication in correcting a particular type of malocclusion, or the same wire or a wire can be used in different stages of the orthodontic treatment. So in the beginning of the treatment, when the patient presents to you, once we have attached the brackets to the patient's teeth, in the very beginning of the treatment, that is the phase of leveling and aligning, we have to have a wire which is able to engage all the teeth together, right? So we have to use a wire which is flexible in nature. So a wire which has got a more modulus of elasticity or a higher modulus of elasticity, that will be stiffer. So we don't want that in the beginning of the treatment. So we want a wire which is easy to attach to the bracket, which is flexible. So we want a wire which is having a lesser modulus of elasticity in the beginning of the treatment. So the least modulus of elasticity is shown by which wire? So absolutely, every one of you is right. So you have the correct answer as nickel titanium. Okay. Now we have seen this in the live lectures also. I have stressed upon this particular graph. So this is a graph showing stress strain characteristics of a particular substance. So the stress is plotted along the y-axis, the strain is plotted along the x-axis. So this means when the forces are applied to the wire, there is some amount of strain, there's some amount of displacement of the molecules within the body of the arch wire. That is plotted along the x-axis, and the stress is plotted along the y-axis. Now, up to a certain limit, up to a certain point, that is proportional limit. That point is called proportional limit. Up to the point called proportional limit, the stress is directly proportional to strain. Now, this part of the graph is called as Hooke's law. We have studied all this earlier. There's nothing new I'm teaching here. So it also depends upon the internal characteristic of a material, that is the Young's modulus of elasticity. And springiness is inversely proportional to elasticity, to the modulus of elasticity, and stiffness is direct proportional to it, right? Now, if we compare the three types of materials, material C, material B, and material A, what do you think has the most modulus of elasticity? And also, we can see it here as well. This diagram, this graph shows the bending moment versus deflection plotted for a 16 mil orthodontic wire. The red solid line is for stainless steel. The dashed line is for stabilized martensitic nitride. And the green line is for austenitic nitride. You can see the springiness of the austenitic nitride is the maximum. That means it is the most flexible wire out of the three. So the more the flexibility of the wire, the lesser will be the modulus of elasticity of that particular substance. Okay? That's why we will choose option A as the nickel titanium. Right? All right. We have studied this. Next question, Maryland bridge can't be given in which of the following clinical condition? Is it a cross bite, open bite, bilateral cross bite, or a deep bite? What do you think should be the answer? What do you think should be the answer? What do you think should be the answer? Diksha is saying I marked beta titanium. Unfortunately, it's okay. Doesn't matter. It was little tricky. That question was little tricky, but don't worry. I'm sure you must have got it. You must have got other questions right, Diksha. So no worry about it. No need to get disheartened about it. All right. So Maryland bridge cannot be given in which clinical condition? Cross bite, open bite, bilateral cross bite, or deep bite. Now, what is a Maryland bridge? First of all, it's a conservative fixed partial denture. If suppose you have a lateral incisor here, we are talking about the upper teeth, upper anterior teeth. We have a central incisor. The other central incisor is missing, and we have a lateral incisor. So Maryland bridge is given to replace this central incisor. The yellow colored tooth has to be replaced by means of a Maryland bridge. Actually, a more comprehensive way of replacing that tooth should have been a dental implant, because it lies in the aesthetic zone. It lies in the aesthetic zone, correct? But the patient has opted for Maryland bridge for whatever concerns, whether it was economic concerns or anything, I don't know about it. So only a single tooth is replaced. Only a single tooth is replaced. So only a single tooth is replaced. In that case, it has to take support from two adjacent teeth. So one, it has to take support from the lateral incisor on the opposite side and the central incisor from the opposite side on the lingual aspect, not on the buccal aspect, because it has to be in the aesthetic zone. That is called Maryland bridge. Okay. Now, it cannot be given in which condition? If you're talking about the orthodontic aspect of this, it cannot be given in crossbite, open bite, bilateral crossbite, or deep bite. Now, what do you think should be the strength of this particular prosthesis? Is it comparable to that of a dental implant, or is it comparable to that of a fixed partial denture? I mean, the complete bridge, which involves crown preparation of the central incisor and lateral incisor and replacing the three teeth together as a single unit. What do you think? Does the strength of Maryland bridge is equivalent to that of a fixed partial denture? No, I don't think so. It must be little less, because the Maryland bridge is cemented by a wing-like preparation on the lingual aspect by means of adhesive composite. There's a very conservative preparation on the lingual aspect of the adjacent teeth, and the Maryland bridge is just stuck to that area by means of adhesive composites. So naturally, we have lesser surface area to involve that tooth. We have a lesser surface area to involve that tooth. That's why the bond strength will be compromised in this case. Now, once the bond strength is compromised, you don't want excessive tooth contact. So crossbite, it can be given. Open bite, it can be given. Bilateral crossbite, it can be given. It's not mentioned whether the crossbite is anterior or posterior, so we'll assume it could be in the first option, it could be anterior crossbite. In the third option, it could be posterior bilateral crossbite. But in case of deep bite, it cannot be given. Why? Because deep bite involves a lot of pressure from the lower anterior onto the lingual aspect of the upper anteriors. Now, as I said, if the bond strength is compromised already, you don't want that bond strength to get compromised even further, no? You don't want any excessive contact between the teeth. So that's why deep bite patients, the Maryland bridge is a contraindication. So the correct answer will be option number D, that is deep bite. Okay. So, okay, many people have marked deep bite. So yes, you are right. Diksha has marked open bite. Okay, no problem, Diksha. Never mind. You must have got other questions right. No worries about that. Now, which of these treatments removes the cause of malocclusion? Now, this is a trickier way to ask a question like which of the following procedures will be required, which of the following procedures will be required to remove the particular cause of a malocclusion on a permanent basis. You can see that way, you can modify it that way. Now, what is the permanent way of removing the particular cause of a malocclusion? Is it frenectomy, supracrustal fibrotomy, or rest of the two options? If you can help me out, I can just write it down here right now in front of you. Now, frenectomy does not remove the cause of malocclusion. It does not remove the cause of malocclusion. Supracrustal fibrotomy does. So there's a procedure called supracrustal circumferential fibrotomy, also called as Edwards procedure. Also called as Edwards procedure. Since it was invented by Edward, the procedure is named to honor him. Now, again, we have seen that in the notes, in the live lecture, in the recorded lecture. So circumferential supracrustal fibrotomy is also known by the term precision. It is not precision. It is not precision. It is precision. So please make a note of it. It is precision, not precision. So you can find it that in the notes in the chapter on minor surgical procedures. I think that's chapter number 26, I guess. Yeah, 26. Yes, correct. So it is known synonymously by circus size procedures or Edward procedure, as I said. The supracrustal, one second. The supracrustal gingival fibers have a high propensity for relapse following rotation correction. So these fibers are surgically excised following mild overcorrection of rotated teeth. So basically what we are doing, the objective of this kind of this procedure is to remove the group of supragingival crest fibers, because it's these fibers, these collagen and elastic fibers, they are going to move the tooth back into the correct position following the orthodontic treatment. So they are the fibers which are primarily responsible for causing relapse of the treatment. So the best way to correct that relapse, I mean, the best way to prevent that relapse from happening is to slice, is to sever those the circumferential gingival fibers only by the procedure called as CSF. Okay, so we use a Bart Parker knife. It is inserted into the gingival crevice, and 360-degree rotation is given along the gingival crevice circumferentially of the tooth in order to sever those fibers, and the new fibers which are created, which are remodeled, they get remodeled in that particular orientation, which do not lead to relapse of that rotation correction. Okay, so we have done this. We have already talked about this in the live and recorded lecture. So circumferential supracrustal fibrotomy removes the cause of malocclusion. to to eliminate the need for permanent retention. You can put it that way as well. Okay. All right. So I have the other options as auto transplantation and one more was corticotomy. All right. So auto transplantation is a procedure where one tooth is replaced by the other tooth within the same mouth itself. Like if there's a congenitally missing or not missing, I would say there had been an accident or the patient might have lost the upper central incisor. In that case, the lower second premolar can be transplanted into that space of this upper central incisor, followed by reshaping or putting a crown in respect of the contralateral central incisor. That is auto transplantation. And corticotomy is a method. It's again an invasive method. It's a minor surgical procedure to accelerate the tooth movement. We remove a part of the gingiva above the teeth where we want the teeth to move at a rapid rate. We remove the gingiva, we expose the periosteum of the bone, of the underlying bone. We create certain cuts, not through and through. We create partial osteotomy cut to accelerate the rate of tooth movement, and then we put the bone graft in that area, and then we close the sutures. So what happens after this? By a process called regional acceleratory phenomena or rapid acceleratory phenomena, the the process of bone turnover, it increases manifold. Right? There is increased inflammation in that area, and inflammation leads to remodeling of the bone at a very rapid rate. So hence increasing the rate of tooth movement. Okay, so we are accelerating the rate of tooth movement by means of corticotomy procedure. So the correct answer will be option B, that is supracrestal circumferential fibrotomy. Okay, I have certain comments here. Question is, which of the following will remove etiology not treated malocclusion? Franctomy for midline diastema. Franctomy can be answer to. I think franctomy is answer. No, franctomy will not be the answer because franctomy is a surgical procedure to allow the orthodontist to close the spaces between the teeth. Okay. It removes the cause of malocclusion. It does not remove the cause of malocclusion, rather. It is an adjunctive procedure to close the spaces of the teeth. That frenectomy, that fibrous frenum, it is attached to the interdental bone between the two central incisors. If the frenectomy procedure is done properly, we are freeing the interdental area so that the teeth can be brought together and the diastema can be closed. So I think the better answer will be the supracrestal fibrotomy in this case. Okay. All right. Next question, again an image-based question. You can help me out with the options. Which stage of CVMI is shown in the picture? I think this was a very similar image which was asked in the exam, without the yellow dot, of course. So can anyone help me? Can anyone help me in this particular, in recalling the particular options for this question? I'll be helpful. Again, we have discussed about CVMI in the notes, in the live lectures, as well as in the recorded lecture, and also in the live sessions which we have taken. Now it was given by Hassel and Farman. It was rather modified by Hassel and Farman. Originally, the CVMI stage was given by Lampersky, which were later on modified by Hassel and Farman in the year 1995. So what they found out, they classified the different stages based on the morphology of the body of the vertebra, how the morphological characteristics of the body of the vertebra, they change. The classification system is based on that. So the first stage is called stage of initiation, followed by acceleration, transition, deceleration, maturation, and finally completion. Right? Okay. So options were C6. Okay. What else were the options? C6. What else were the options? C2, C3, C4, C6. C2, C3, C4, or C6. Now, which stage of CVMI is shown in the given picture? That was the question. Okay, before that, I want to tell you that we have talked about it earlier. So, this is Hassel and Farman's method. They found that the shapes of the cervical vertebrae were found to differ with different levels of skeletal development. They found the correlation between the skeletal maturity indicators seen in the hand-wrist radiograph and cervical maturity indicators in lateral cephalogram. As I said, we have initiation, acceleration, transition, deceleration, maturation, and completion based on the morphological characteristics of the body of the sphenoid, body of the vertebra of C2, C3, and C4 specifically. So the first is CVMI 1, followed by CVMI 2, CVMI 3. So what happens here? You can see here how the body of the vertebra undergoes transition in the morphological aspect. You can see the dorsal aspect, the superior dorsal aspect, it slopes posteriorly, and that slope reduces gradually until the body of the vertebra becomes somewhat squarish in nature. So from a horizontal rectangular configuration, it assumes a squarish configuration followed by vertical rectangular configuration all the way from deceleration, maturation to completion. Also, you can see the inferior border of the vertebra, of C2, C3, and C4, that also undergoes conformational changes. From being flat, it undergoes excessive concavity. Okay. So initiation, acceleration, and transition, you can see very less concavity in the inferior border of the body. The concavity starts to occur between transition, it accentuates to deceleration, it further accentuates to maturation. Finally, it has deepened completely till the time the stage of completion has been reached. So that is how the difference in the morphological characteristics of the cervical vertebra is seen in a lateral cephalogram. Now let's come back to the question. Which stage of CVMI is shown? So I don't know what exactly the question was. One second. What stage of CVMI is shown? Now, if you see, the body of the vertebra was like this, little bit of concavity. Or the body of the vertebra was like this, more concavity and more vertical, more vertical rectangular position orientation of the body of the vertebra. Can you help me out in that? What was the exact image which was asked? Whether it was first image or the second image, because we have different answers for both the images. Can you exactly point out which image was that in the exam? So Florence is saying all borders of C2, all borders of C1, C2 and C3 are in concavities in shape. Okay. All borders are having concavities in shape. And Herschel is saying it was square shaped with concavity. All right. So it was square shaped with concavity. So in that case, if it is square shaped with concavity means we have transition. So it is C3. If we have to go with Herschel, who is saying it was square shaped with concavity, so we have C3 as the correct answer. That is analogous to transition stage. But if somebody is saying it's a second image, Dr. Zakia Ather is saying it is second image. MR is also saying it is second image. Who else is saying second image? Home for Words is saying it was square. So as I said, if the image was squarish, we will go for C3, that is corresponding with transition stage. Whereas if we have more of a rectangular stage, we will go for C4. C4 for rectangular stage. rectangular stage with little concavity. But if we are rectangular stage with much more deepened concavity, then C6 will be the answer. So this is a subjective question basically. I cannot say for sure what exact figure was asked in the exam. So based on your inputs, based on the students' inputs, many of you have given different inputs. So based on the different possibilities, I have given all the three answers for you. So it is up to the exam setter and it is up to the proper recall that what exact answer should be marked in the exam. Ackerman profit classification group 1 stage 1 is what? Again, we have one more question on Ackerman profit classification. We have discussed this earlier as well. So group 1 stage 1 will be intra-arch alignment. Okay. This is again we have discussed. Group 1 is intra-arch alignment. Group 2 is profile. Group 3 is transverse deviation, sagittal deviation, vertical, transsagittal, sagittal-vertical, vertico-transverse, and finally the most complex, that is the group 9, that is trans-sagittal-vertical alignment in all three planes of space. We have discussed this again. All right. So there was a question. Okay, I'll come back to the question. There was one more question, which is the newer version of beta titanium wire or TMA wire. It is the newer version of beta titanium or TMA wire. Can you recall the options for this particular question? Because I was unable to do so as I have got the feedbacks from different students. Can anyone of you recall the options for this question? Can anyone of you recall the options for this question? The newer version of beta titanium wire should be? Can anyone recall the options for this particular question? Okay, one option is OptiFlex wire. So this cannot be the answer because it is an aesthetic arch wire. It is not a version of TMA wire. Then second is super cable. It is a super cable. Third can be coaxial wire. And the fourth option will be dual flex wire. Dual flex wire. So are you sure these were the four options? Are you sure these were the four options? One second. One second. I'm just reading the options provided by you guys. OptiFlex, super cable, coaxial, and finally dual flex wire. All right. So what do you think should be the answer? What do you think should be the answer? What do you think should be the answer? Okay, we have one more option as copper night tie as one of the option. Okay, let's consider that as well. Copper night tie. So copper night tie cannot be the answer. It cannot be the answer because it's a different form of a nickel titanium wire. It is a heat activated night tie wire. It is not beta titanium wire. So we can eliminate OptiFlex. We can eliminate copper night tie. What are we left with? Okay, copper night tie. Was it CAN or CNA? Okay, I'll take one more possibility as CNA. CNA wire. CNA means Connecticut arch wire. Connecticut newer arch wire. That's the full form of CNA. Connecticut newer arch wire. It was developed at Connecticut. It's a place in USA. That's why it has been termed based on that place where it was invented. So Connecticut newer arch wire is standing for CNA wire. Okay, we have coaxial was not there. Okay, so we can eliminate this option. Coaxial option was not there. Dual flex, super cable, optiflex, and super cable. All right. So as the name suggests, newer version of beta titanium arch wire is Connecticut newer arch wire or CNA wire. That is the correct answer. Optiflex, I said it's an aesthetic arch wire. It cannot be the version of TMA wire. Copper nitride cannot be the version of TMA wire. Super cable, I think, is made up of stainless steel. It is not made up of beta titanium. It is made up of stainless steel wire. And dual flex wire, it is made up of two different materials. One is stainless steel, one is nickel titanium. It is stainless steel plus nickel titanium. Okay. So I told you Optiflex was not okay. It was, even if it was not an option, we can eliminate it. So CNA wire is the correct answer for the question. That is Connecticut newer arch wire will be the correct answer. Okay, that is the correct answer for this question. Now, example of one couple force system. Again, we have discussed this multiple times in live lectures, recorded lectures, YouTube sessions, GT discussions, whatnot. I must have explained this concept at least, if I'm not wrong, at least 25 to 30 times. Okay, so one couple force system you already know. It is also called statically determinate system, and two couple system is known as statically indeterminate system. You know that already. So whenever an intrusion arch is made having a single point contact between the arch wire, there's a single point contact between the arch wire on the incisor segment that makes it as a determinate one couple system. So example could be a cantilever spring. You can see there's a single point contact here, and the wire is bringing the impacted canine down. So we can actually measure the forces and moments generated, which can be known precisely by means of certain instruments. So that is why it is called a one couple system, statically determinate system. Whereas statically indeterminate or two couple system, the example will be utility arch, where we have multiple contact between the arch wire and the bracket slot. So there is so the possibility of knowing the exact magnitude of forces and the direction of couple and the magnitude of couple precisely is next to impossible. So we cannot know for sure what is the exact magnitude of force and what is the exact direction of moments and couple at different points of contact. So that makes it statically indeterminate system, also called as two couple system. So in this example, in this question, the example of one couple force of system of forces will be none other than cantilever spring. So I think most of you have marked it as correct answer. It is cantilever spring. Okay. Next, choice of space maintainer opted in case of bilateral loss of primary first molars in a 5 years old child will be. Now, two or three things have to be noted here. We have bilateral loss of primary first molars in a 5 years old child. Now, 5 years old child, the central incisors have not yet erupted. Number one. The permanent molars also have not erupted. Number two. And we have bilateral loss of primary first molars. We have bilateral loss of primary first molars, correct? So the correct answer in this question will be, it should be bilateral band and loop space maintainer. Suppose if the question would have said it's a 6 years old child or it's an 8-year-old child. Now 8 years old child would have had erupted permanent central incisors, the permanent first molars. In that case, the answer would have been lingual arch. But since it's a 5 years old child where we neither have the incisors erupted nor we have the molars erupted, prominent molars I'm talking about. So it is better to maintain the space bilaterally using bilateral Madden loop appliances. So it's a fixed space maintainer, non-functional type. Excuse me. So band and loop, it looks like this. So I think this is the situation they have asked in the exam. So we don't have the primary we don't have the permanent incisors, we don't have the permanent molars. So it is better to maintain the space on both sides using bilateral band and loop appliances, band and loop space maintainers. Excuse me. Okay. All right. All right. So next question, I think this was taken by Dr. Priyanka as well, just before my session. Distance between X-ray source and the misradial plane of the patient for cephalometry would be. Again, it's a direct question. We have discussed that in the chapter on cephalometrics, in the live lectures, in the recorded lectures, as well as in the notes as well. So this is the particular configuration of a cephalostat in normal setting. So the distance between the X-ray source and the misradial reference plane of the patient will be, this is the misradial plane of the patient. The distance between the X-ray source and the misradial plane of the patient will be 60 inches of 5 feet. It's a very, very basic question. We have discussed this many times earlier. So the answer will be 5 feet. No doubt about it. It's a very simple question, direct pickup question, that is 5 feet. Now, one more option, one more answer, one more question could have been asked from this particular image is that the distance between the misradial plane of the patient to the film plane, to the point where the extra film is placed, should be 15 centimeter or 6 inches. That is the correct answer. So, since that is not asked as a question, we'll stick to the 5 feet as the correct answer. Okay, so 5 feet is already answered. Now, length of the mandible can be measured in a cephalogram by which of the following parameters? I think one of you had asked this in the chat box initially. So that this question is for you. So length of the mandible can be measured in a cephalogram by means of which parameters? Now, these are the landmarks on a dried skull. Since it's an anatomical landmark, it's a skeletal landmark. So I have restricted myself in measuring, in pointing out only the skeletal landmarks in this particular figure. Now, McNamara and Harwold, both of them have said the correct way of measuring the effective length of mandible on a lateral cephalogram is from condylion to pogonion. It's from condylion to pogonion. We have discussed about condylion. We have discussed about condylion earlier in the live and recorded lectures, as well as you have this very figure in your notes as well. So condylion is the superior and most posterior point on the outline of the condyle of the mandible. And pogonion is the anterior-most point on the bony chin. You already know that. So the effective mandibular length is so called effective mandibular length that is measured from condylion to pogonion. Okay. Now let's look at the options. Condylion, pogonion, absolutely. Gonion, gonathion, pogonion to gonion, or gonion to menton. So what will be the correct answer? Option A will be the correct answer. Right. So let's see. Okay, gonion to nathion. Okay, let's see. Gonion to nathion could have been one answer. Then we have pogonion to gonion, pogonion to gonion, and we have gonion to menton. We have gonion to menton. I'll take a different color for that. We have gonion to menton. So these three measurements, they can be used for measurement of length of mandibular body, length of body of the mandible. These three parameters can be used for measuring the length of the body of the mandible, but for measuring the effective length of the mandible as a whole, I think that was what was asked in the question, no? The length of the mandible. So we have to assume the question is asking the effective length of the mandible, complete length of the mandible. That is measured from condylion to pogonion. Condylion to pogonion according to McNamara and Harwold's analysis. All right. Condylion to pogonion will be the correct answer. All right. Okay. Okay, Lakshmi Narayan, I just said no, it is according to McNamara and Harwold analysis. Okay. The question might have had Harwold's analysis as one of the phrases in the language. Maybe that could have been skipped, but doesn't matter. Doesn't matter. Harwold's analysis or McNamara analysis, they always say that the effective length of the mandible will be measured from condylion to pogonion, no matter whatever the question is asked as the body, as the whatever the language of the question was asked in the exam originally yesterday. All right. So that's all from my side. Now, I want to repeat the disclaimer again, which I mentioned in the beginning of the session. There were many questions which were incomplete. There could be some questions which were not there, or there could be certain options which were not there altogether in the exam. So, no one is to be blamed here. It's a recall, it's a memory-based session. So there could be a possibility that the options or the answers might not be correct properly sometimes. So I want you to recollect all the correct answers, correct questions properly. And if you have got any doubts, you know where to find me. I'll do my best. I'll do my best to help you out, guys. There was one more question on mixed analysis, mixed dentition analysis, Tanaka Johnson analysis question, numerical question. All right. So I'll just make a note of it here. There was a question on Tanaka Johnson analysis. So if it was a numerical question, so I think you must have been given certain numerical values, and you have to apply that particular formula to calculate that the width of that unerupted tooth. Am I right? Am I right? Okay. Okay. So in that case, you have to apply that formula. It's a very basic, straightforward formula which has to be applied. So what should be the answer? 1 second. Just hold on. So the formula is y equals to 10.5 plus x upon 2 and y equals to 11 plus x upon 2. This is for the mandibular incisors. No, sorry. This is for the maxilla and this is for the mandible. Right. So this was the mathematical formula which you were supposed to apply to come to a proper conclusion, to come to a proper answer. Since I do not have those values, I cannot do the exact mathematical calculation for you. I have the options as, okay, somebody has written the options. Aprajita Das has given the options. 21.25, 20.25, 20.75, and we have 21.5. I hope I assume the measurements are in millimeters. So as I said, As I said, I cannot give you the correct answer if I do not have the exact mathematical values for those questions. So I leave this answer for you. I have given you the exact mathematical formula. You can apply it yourself if you remember the exact values of the question. And then we can get back to this question later on. All right. So that's all from my side. I'll hand over the question to Dr. Kishan Rao now, who will take the session forward. That's all from my side. Have a good day, all of you, and all the very best.
Thank you so much, Dr. Kunal. It was a wonderful discussion. I also learned so many things from you today. Coming to general surgery discussion.
21.25. Hi, Dr. Kishan. I hope you are fine. I hope you are good this day. So I'll hand over this session to you.
Sure.
The screen is all yours. The screen is all yours.
Yeah.
Thank you, sir. Bye.
I hope I assume the measurement.
Rishabh, can we start? Mr. Rishabh? Okay. So, my dear students, welcome for this general surgery discussion on recently concluded NEET MDS entrance exam. I'm very happy today to discuss these questions because my students would have not felt any difficulty in answering any questions related to general surgery. I went through the questions; they were very simple and very straightforward questions, and I'm very sure you all have got it right. Anyway, we will discuss it once again in with the details. The first question was, which of the following is the most common cause of free flap failure? Okay, so in skin grafting a topic, when we are discussing, we have discussed about the grafts and the flaps, what are the complications of the skin grafting, flaps and all. So in that I had discussed the complications of the flaps. So most common cause for the flap failure or the flap not taking up being, the options were arterial thrombosis, venous thrombosis, anastomotic leak, and infection. Yes, all four are the complications, agreed. But the most common cause for the free flap means we are taking the one organ or the one skin from one side and putting on the another side completely with all its vessels intact. So the most common cause is the venous thrombosis, because we are anastomosing the vein to vein. That time there may be some technical errors like kinking, some maybe it got out twisted, because as you know, the veins have got the very thin layers, so they are way more prone for this kind of kinking and all. So if anywhere stagnation of the blood flow is there, the blood gets clotted or thrombosed. That's how there is venous congestion takes place. Venous return doesn't happen, because of which the venous congestion edema occurs and free flap gets doesn't get taken up. Okay, it fails. So that's the most common cause. venous thrombosis. Later on, there could be arterial thrombosis, anastomotic leak. All this can happen, but the most common being the venous thrombosis. The easy one, straightforward, factual. Second question was, yeah, Abhishek is asking, why can't it be infection? Yes, dear, you are right. It can be infection, but as I told, it's not a very common cause. Okay, common cause. All the four can happen. Okay, but the most common being the venous thrombosis, because any surgeon while doing the flap, I'm very much careful or concerned about the anastomosis of the veins, because anywhere little narrowing of the lumen, little kinking, little if there is a pressure like any hematoma or anything causing pressure over the veins, because they are very thin and very fragile structures, so can easily get blocked, can easily get compressed by the external pressure. So that's the most common cause. Hope it's clear. The later on, after 5, 6, 7 days, even the infection can set in, and that can also cause flap failure. But initial 1 day, 2 days, most common cause being venous thrombosis. Second question: a patient comes with gunshot injury to face with expanding hematoma and stridor. What could be the immediate next step? My students are expert in this trauma topic. In however twisted way they give the answer, they give the question, the answer remains the same. That is, in any trauma case, what we are concerned about the most is the airway, right? So let's see the options. In the patient is having expanding hematoma and stridor, means his airway is getting compromised. What is the immediate next step they are asking? Not the best step. Immediate next step, what you are going to do? CT scan. You can't do a CT scan on a dead body, right? Because CT scan takes time. By that time, patient may not be alive. So immediate surgical exploration, you don't know from where it's bleeding or anything. That may take time. Cricothyroidotomy and nasotracheal intubation they have asked. Nasotracheal intubation, right, but usually we avoid in case of any facial injuries or facial hematomas, because it may further worsen the injury. So we usually avoid intubation in case of any facial trauma. What we prefer is to secure the airway immediately. What you can do is cricothyroidotomy. The cricoid membrane, just below the thyroid cartilage, there is a cricoid membrane. Okay, there we put a needle and secure the airway before even the entire it will get compressed with the before the hematoma compresses the airway, we secure the airway by a tube using cricothyroidotomy. That should be the immediate next step. Later on, you can go for tracheostomy and other things, and surgical CT scan, CT angiography, you can get it done and see from where it's exactly bleeding and all. Then you can do the surgical exploration if it's required. Okay. So answer here is intubation. Dr. Dentist is telling, yeah, supposedly it should be the best option, intubation. But in the given scenario, suppose in any case of facial trauma, we usually don't prefer it. Okay, unless you are very pretty sure that his no major fractures or no major bleeding present, we can go for intubation. Or else, in such in a emergency scenario, we prefer not to do intubation, because for sometimes it may further aggravate the injuries or fractures. So safest one is cricothyroidotomy. The answer is C, cricothyroidotomy. Third question was, a 55-year-old male presents with a slow growing swelling in the parotid region. Some benign, slow growing by they mean to, it's a very benign swelling in the parotid region. FNAC reveals pleomorphic adenoma. As we know, pleomorphic adenoma mostly it is benign swelling of the parotid gland. What is the correct treatment for the same? Correct means they are asking the best treatment. Okay, what is the best treatment for the pleomorphic adenoma? So they have given it in a lengthy manner, but the question is very straightforward. What is the treatment for what is it, pleomorphic adenoma? So what's your answer? Is it total parotidectomy with facial nerve sacrifice for benign swelling, or it local excision, just locally take it out, or core needle biopsy and observe, or superficial parotidectomy? All your answers are correct. Swapan, Amarendra, Florence, Shreya, all of you got right. The answer is superficial parotidectomy. Okay, it's a benign swelling. The chance of recurrence are less, so need not have to go deep into the deep lobe and injuring the facial nerve and are not required. just do superficial parotidectomy. Local excision is not enough because there will be some pseudopods going into the normal tissue also. So if you do local excision, okay, so answer is D. Aparajita is telling, sir, while answering this question, I remembered the video lecture where you were telling us how Strider patient makes sound. Yes, Aparajita, see, my some crazy acts helped you in remembering the answer. That's what. Okay. Thank you. Glad you got it right. The fourth question, a patient is brought to the emergency department after collision in road accident. My dear friends, I had stressed so much on trauma topic, right? Trauma. And you're all very expert with these. See, so many questions on trauma they have asked. He is intoxicated, uncooperative, and does not elicit any cervical spine tenderness. What steps should be taken for primary prevention of C-spine injury? Prevention of C-spine injury, they have asked. So I told you and again stressed, even yesterday's, I told you the first question, what I in the groups I had put no the probable questions. That first question was this only, right? I had expected this question, yes or no? I have correctly guessed this question. If you're there in my groups, trauma topic, this one cervical collar application question will definitely be there. My first prediction came right. So whatever it may be, in the airway with cervical spine protection with the cervical collar is the answer. So I'm very sure all of you have got this right. Thank you. So next question. A 10-year-old girl comes with painless bluish swelling. In all the my grand tests or class test, I have given one this image-based question on this. Yes or no? Yes or no? This question was there in all my tests because I knew this will be an image-based question. I don't know whether they will give image or not. I don't know. But here is a question on ranula. Is a bluish swelling in the floor of the mouth is ranula. So they have asked what is the treatment for ranula? With the removal of gland, incision and drainage, antibiotics, or what was the other option? Anybody remember? Anyone remember? What was the last option? If not, its answer could be either excision, removal or excision of the ranula along with the underlying gland. That's the best option. Best treatment would be A, removal of the removal of the cyst along with the underlying gland. It is the best. Or else marsupialization. Another option would be just open up the outermost layer and just marsupialize the ranula. That's another option. Whatever the secretions are there, extravasation cyst is there, all the extravasations will come to the mouth and it can be swallowed. Okay, so those are the two treatment. Sclerotherapy may not be helpful. Incision and drainage, once it can be drained, again it will refill because the capsule is there intact. Okay, so the answer here is removal of the underlying gland along with the cyst. Very good. Okay, another option was sclerosant. Okay, sclerotherapy is not the good option here. Okay, so best answer would be A. Okay, although it's not, this question is not pertaining to surgery, let me discuss this. Oxidized cellulose is used in clinical dentistry for which of these purposes? Can you please answer? Styptic, antiseptic, obtundant, anti-plaque agent. I'm sure you know the answer, but these words are little confusing. Styptic means hemostatic. Styptic means hemostatic. Antiseptic means obtundant means pain reliever, analgesic. Anti-plaque agent means doesn't plaque formation, it avoids this thing. Answer, all of you are right. Its answer is A. Styptic means it's a hemostatic oxycellulose layer. We put it as a hemostatic agent. Okay, all of you are right. Nikesh, Sai Charan, Swapan, Aisha, Janani. I'm very sure you'll get very good ranks. I'm very happy. I'm feeling very happy. My students all got almost all the answers right here. Abhiram, good, very good, very good. So next question. A patient presents with bleeding from the gingiva after application of gingival retractor, okay, for dental procedure. Which of these can be used to control the bleeding? You know this is a common sense. Normal saline, will it help in any way? It will help in cleaning up, but not stopping the bleeding. Povidone iodine goggles, no. Sodium hypochlorite, no. Gelatin foam, yes. Sangu Satish is right. Okay. Florence asking what is the answer for prevention of C-spine injury? It's a collar. Philadelphia collar we applies. There is an option, no? Collar, what is that? Cervical collar application. D is the answer. Okay. So here is the answer is gelatin foam with pressure. You apply the, it's a again hemostatic also. Okay. Gelatin foam, just like oxidized cellulose. So answer is D. Correct. Adya, Aparna, Adil Muhammad, all are right. Monisha, very good. A patient underwent a unilateral neck dissection. 5 hours after the surgery, he experiences pain and swelling in the neck. What's the most probable cause? This we have discussed in case of maybe thyroid. Thyroid, I have discussed thyroid topic. What are the complications of thyroid surgery? I discussed, during which I told anyone after 5 hours of surgery, he's in the post-operative ward, patient suddenly feels discomfort in the neck or pain in the neck or a visible swelling is there. What it can be? You're all, come on. Is it? Tell me. I'll not give any options. You tell me the answer. Muskan is telling option was the airway problem. Okay, airway problem. Okay. Okay, airway problem is correct. Okay. Your options is like hemorrhagic shock. No. It's not hemorrhagic shock. It's very good. Dhruv is correct. Dhruv is perfectly right. Aisha is right. Okay. Airway obstruction, they will have stridor, not just pain or the swelling. They'll have mainly compressive. Yeah, this can, bleeding can lead to hematoma that can compress the airway and can lead to airway obstruction. But here the answer is, what's the most probable cause they are giving for the after 5 hours of surgery having pain and swelling? They were given swelling because it's hematoma. Hematoma is because of the hemorrhage. Okay. So answer here is A. It's a reactionary hemorrhage. Immediately after surgery, it's a reactionary hemorrhage. Okay. If there is a reactionary hemorrhage of not there, they had given only about airway obstruction. But for airway obstruction, there could be some only pain and swelling is not suggestive of airway obstruction. For airway obstruction, there should be some symptoms like any stridor or breathlessness. All those things should be there. If it was mentioned like anything like breathlessness patient is having or stridor, then it is suggestive of airway compromise. Maybe again because of the hematoma only. But in the question, it was as per I have given, it's told that only patient is having pain and swelling. It's suggestive of tension hematoma because of reactionary hemorrhage. Okay. So next, a 55-year-old female with chronic tobacco chewing and alcohol abuse history comes with a lower lip lesion. The lower lip, there is a probable malignancy. Okay. On biopsy, it comes out to be squamous cell carcinoma. Which of the following lymph nodes would be? And it's a clinical anatomy question. You tell me what's the lymphatic drainage of lower lip. That's the answer. Okay. What's the lymphatic drainage of lower lip? Because squamous cell carcinomas drain via lymphatics from lower lip. Whether it will drain to the occipital region, to the parotid region, submental or retropharyngeal region. Yes, very simple, straightforward question. It is from the lower lip, it will drain into submental. That is 1A, level 1A of the cervical lymph nodes. It will drain to. Correct. So question number 9. The right answer is C. In 8th question, Devans Joshi is telling, sir, they didn't ask about cause. They asked what will happen due to this pain and swelling in 8th question. It's not air anymore. Okay. What will happen due to pain and swelling? Yeah, swelling, yes. If this was the question, if I asked Devans is telling If what will happen because of there is a patient having pain and there is a swelling is there, what will happen because of this? Yes, then it will lead to airway obstruction. If this was a question, if the cause was asked, then hemorrhage. What will happen because of the hematoma or hemorrhage? Then the answer would be airway obstruction. It can compress on the airway and patient may have dyspnea or okay, whichever option was there. If question was like Devansh is mentioning, if what can happen because of the swelling, definitely airway obstruction. So we have to immediately act. We have to open up the this fascia. What are the fascia? Skin and fascia we have closed. We have to immediately open it up and able to drain out the hematoma in the bedside only, not taking to OT and all. In the bedside, open up the stitches and evacuate the hematoma. Then you can shift to the OT, and where is the bleeder is there, you can stop. Okay, home forwards. Airway obstruction is the right answer then. Okay, if that was the question, airway obstruction is the right answer. Okay, good. Thank you for that update. So this is clear, right? It's a submental. A patient comes with non-healing ulcer on the lateral border of the tongue. Just yesterday I had given you, right? This prediction also came true. I told you there will be one question from this topic for sure, that is oral cavity malignancy. So again, on tongue they had given in the so many of my tests also had given this question, the staging of the tongue tumor. Biopsy reveals squamous cell carcinoma. Which of these is the most important prognostic factor, they have asked. As we have discussed in the class, what is the important thing in very good, Florence, very good. Before I could ask, he has answered. Size of the tumor, no, it doesn't matter to us. Size of the tumor, depth of the invasion, perineural invasion, histological grading. Answer is depth of the invasion is very, very important for us. Depth of the invasion, okay. Because that's why in the TNM staging they have included for this particular tumor, they have included depth of the invasion also as a criteria to know the prognosis. It's very, very important. All the four are definitely important. I'm not saying they're not, but the most important being the depth of invasion, to which layer it has spread. Okay. So answer for this 10th question is B. Next question is, a patient presents with a fluctuant swelling on the scalp that is present since birth. MRI reveals keratin filled mass. This is most likely to be. This is a bit twisted question. Okay. But with common sense, you can answer. With common sense, you can answer this. It's not very difficult, but bit I felt it's a bit application level. Okay. So the clue here is the fluctuant swelling in the scalp since birth. So it's some congenital swelling. Out of these four, which all can be congenital? Dermoid cyst, epidermoid, sebaceous, pilar. Among these two, congenital C and D are ruled out. Sebaceous cyst is not congenital. Pilar cyst is also not congenital. So C and D are ruled out. A and B can be congenital. Okay, A and B can be congenital. Both are fluctuant swelling on the scalp. So the next clue they are giving is, okay, next clue what they are giving is MRI reveals keratin filled mass. Keratin, from where do you get the keratin? Keratin is in the skin. Keratin is in the epidermis. Squamous epithelium, the keratin is present. Dermoid cyst mainly contains the adnexa, like sebaceous glands, other like other adnexal parts of the skin. Okay, sweat glands, other things, but not the epidermis. It will mainly dermal components it will have, dermoid cyst. Whereas epidermoid means it's a type of inclusion cyst. From epidermis, something has come into the dermis. It's called epidermoid. Epidermis coming in like a dermis, epidermoid. So in epidermis there is keratin, okay, of the squamous epithelium. So it is into the dermoid now, inclusion, from which there is a foreign body reaction leading to a swelling. Okay, so the answer here is epidermoid cyst. Since the both are the A and B can be answered, but since they mentioned that keratin filled mass, so the better answer is epidermoid. Epidermoid contains keratin, whereas dermoid cyst contains mainly other dermal elements like sweat glands, sebaceous glands, and other things. Okay, hope it's clear. Answer here is B. Okay, next question. A patient has a midline swelling of the neck that moves with swallowing and protrusion of the tongue. My students will remember my joke. What is that? Only one swelling in the entire world, including the aliens and other things, right? Only one thing in the entire universe which moves with both swallowing and protrusion of tongue, which is that thyroglossal cyst. Yes, thyroglossal cyst. So they have asked what is the first investigation of choice. They are not asked the best or the which is the investigation of choice. Here question is which is the first investigation you are going to do. Always any neck swelling, any swelling of the thyroid or this thing. What is first is always non-invasive. What is first non-invasive test you are going to do is USG. Okay, USG. Okay, USG is the answer here. Okay, first thing. Then okay, because it's a moves with the protrusion of tongue is a thyroglossal cyst. We are not worried about the thyroid function. Is the answer is USG. USG of the neck to confirm that it is the content inside is a cyst. Okay, so option here is A, USG. Next, again this topic we have discussed in detail of a wound healing. A patient comes with trauma of 12 hours with a grossly contaminated wound. Okay, what would be your management of the same? Please tell me the answer. For a wound, grossly contaminated wound, time doesn't matter for you here because they have given clear cut. It's a grossly contaminated wound. So if it's a grossly contaminated wound, our treatment remains the same. Even if it's 2 hours, 4 hours, 10 hours, 12 hours, 24 hours, the treatment is what's the treatment? What's the golden hour? This I have repeated so many times in the group. Okay, golden period is 6 hours. 6 hours. So this is almost 12 hours now, and it's grossly contaminated. So cleaning thoroughly and primary closure for a grossly contaminated wound after 12 hours not possible. Cleaning and closure with split skin graft not possible, not required also here. Primary closure over a dream can't be done. So answer here is debridement. You have to, whatever the contamination is there, contaminated things, you have to debride it, remove of the dead tissues, and leave it for secondary healing. Secondary healing. Any contaminated wound, better to leave it for secondary healing. Okay, so answer here is D. Option D. Amarendra is right. Okay, option D is the Yami is also right. Shreya is right. Muskan is right. Okay, good. So I think then there are some questions on this thing. What our Beck's triad, right? What the pericardiocentis. I think Rajesh sir has already discussed about that. Any other questions related to surgery? This is the maximum I could recollect from your exams, whatever you were told from. If there are any other questions related to surgery, please let me know. We can discuss that. If not any other doubts or if any more clarification required, please let me know. I think almost all were very straightforward, very simple questions, and from the important topics only. See, this is from the wound healing. I have stressed this a lot, and this is from the thyroid. Again, I told thyroid is a very important topic. Okay, this is a with common sense you can answer this epidermoid cyst, and if not anything from one topic for sure I told was oral cavity that to carcinoma tongue tumor that is there. Okay, cyst question congenital was mentioned in the question. Yeah, congenital cyst only we are told only dermoid and epidermoid cysts are possible as congenital. In that also, why epidermoid? Because it has got keratin in it. Okay, then this this submental applied anatomy, very simple. You can answer this without my help. Okay, and this reactionary hemorrhage or the how it can this hematoma can result in airway compromise, we have discussed this. Okay, in thyroid again, primary hemorrhage, reactionary hemorrhage, a stridor, how to manage this as an intern also. Even a dentist, as a you're a dental doctor sitting in emergency should be able to help this case. I have explained this. Okay, this you know this without any bleeding like this can be stopped with pressure application. And this you all of you have got it right. and this removal of the gland is the best option. You all have got it right. This is the thing we have discussed very much in detail, and you all have got it in depth understanding of this particular topic of trauma and the importance of C-spine protection. I am very sure you all of you have got this right. Superficial periodonectomy, you know this very well. Cricothyroidotomy, yeah, I understand that there is a confusion between cricothyroidotomy and nasotracheal intubation. Okay, but since phase they have mentioned, they have not mentioned where it's exactly mandible, where they are not mentioned. So if it's phase, there may be injury to the nasal bone or the maxilla also. So if you go to do nasotracheal intubation, it will further aggravate. If there is hematoma, it will start bleeding, or there is a fracture, it will become more worsened. So the best one to is to, if there is an injury in the face, you go through another virgin space, that is in the neck. That's better. Okay, hope it's clear. And this is a bit tricky one, I understand. It may be a bit difficult, but still I'm very sure most of you have got this also right. Okay, so I think 13 14 questions from surgery, out of which 12 were very straightforward and all we have discussed in the class. All 14, out of which 13 we have stressed so much in the class, and I have repeatedly told this would be the question. From my yesterday's prediction also, 4 questions were come directly from my yesterday's 10 questions. 4 questions were there in the exams. So I think my students didn't had any difficulty in answering any surgery questions. Any other questions? If not, I think time is up. Your next faculty must be waiting. So thank you so much, friends. I'm wishing you all the success once again. Hope for the best. I'm sure you'll get very good results. But don't stop your preparations. Continue revising till your INACET and till you get a desired branch of choice in your hand. Don't stop revising. Okay. Till then, keep revising. Okay then. Five hours after, Gargi, I have answered that. 5 hours after the surgery, patient complains swelling and difficulty breathing is airway obstruction. If they are given as a difficulty in breathing, it's definitely airway obstruction. Okay. Anything else? Excellent. I'm very happy. There is nothing more satisfying or happiness for a teacher than his students' good performance. Okay, this good performance will definitely fetch you good ranks, good seats. Be hopeful. Okay, be optimistic. But only request is, please keep revising. Please keep revising. Okay, don't stop the momentum. Any help anytime, please let me know. Anything related to surgery, even after you get the PG seat also, don't forget us. Anything related to surgery, we are always there to help you. Thank you so much.